Dr. Valdez and Dr. Bhutan, turn it to you.
So, Dr. Valdez, did you want to open the meeting, or shall I call the meeting to order as the chair of the meeting today? I
believe you have that privilege.
That is my privilege. Thank you. So my name is Dr. Asaf Bitan. I am one of the National Advisory Council members for AHRQ, and it's my privilege to be the chair of today's meeting. And I'd like to call the meeting to order at 10:02 a.m. Eastern Standard Time, and welcome all of the National Advisory Council, the NAC members participating, as well as the many guests at this meeting, and the many staff members at AHRQ that do so much to prepare and make these meetings go so smoothly. We have a lot to cover today, and it's very full and exciting agenda. But before we get to that, I will do a quick introduction of who I am, and also in alphabetical order, ask each of the NAC members present to quickly introduce themselves, and then we'll introduce all the ex officios at the meeting. So again, Asaf Bitan, I'm a primary care physician by training and practice, literally just ran from clinic, as some of you also I know are clinicians can attest. I am the executive director of Ariadne Labs, which is a health systems innovation center at Harvard School of Public Health and Brigham and Women's Hospital. And I also have a role as a senior policy advisor at CMMI for primary care. But my participation in this meeting is not under the auspices of CMMI. I understand that Andrew Auerbach is not here, so then I will go in alphabetical order to the next NAC member, Melinda Bunton.
Hello, good morning. I'm Melinda Bunton, Chair of the Department of Health Policy at Vanderbilt University School of Medicine, and delighted to be here again.
Wonderful. And Caroline Carney. Is Caroline here? I believe she might not yet. Susan Edgman-Levitan.
Good morning, everyone. I'm Susan Edgman-Levitan. I'm a family medicine PA by training, and I am the executive director of the Stokel Center for Primary Care Innovation at Mass General, and I also co-chair our health system, which is now called Mass General Brigham's Patient Experience Leaders Committee, and I also am one of the co-investigators on the National AHRQ CAPS Consortium.
Thank you. Marae Jacobson.
Hi, I am a health economist at the University of Southern California, based at the Davis School of Gerontology and the Schaefer Center for Health Policy and Economics, where I also co-direct the program on aging and cognition.
Wonderful. Omar Latif.
Hi, I'm Omar. I'm the president and CEO of Rush University Medical Center. I'm a pulmonary critical care physician by training. I also went to Harvard at one point, but that was only to get a parking ticket when I went to the bookstore.
My fam.
Hi, everyone. I'm a general internist and president and CEO of Institute for Exceptional Care, which is a nonprofit focused on transforming healthcare for people with IDD.
Thank you. Patrick Romano.
Hello, good morning. This is Patrick Romano. I'm not on video yet because of the hour of the morning in California, and because I'm recovering from COVID, but it's a pleasure to be here. I'm a general internist as well as general pediatrician based at UC Davis Health in Sacramento, California. And I'm a health services researcher who works on healthcare quality measurement and improvement.
Great. David Schmitz.
Good morning, David Schmitz, family physician, professor and chair at the University of North Dakota. And I have a career focused on workforce and healthcare access in rural areas.
Thank you. Jodrika Brown-Spites.
Hi, my name is Jo Brown-Spates. I am a family physician. I'm professor and chair of family medicine, rural health here at FSU College of Medicine. I'm also the lead for our community engagement core for the FSU CTSA, and really focused on advancing health equity through community engagement. Thank you.
Thank you so much. Henry Ting. Is Henry here? Don't see him yet. Yanling Yu.
Good morning. I'm Yanling Yu. I'm living in Seattle. By training, I'm a research scientist, study climate change, ocean circulation, Arctic sea ice at the University of Washington. And because events, my dad died of medical error, I have become a patient safety advocate. I focus on my efforts on healthcare transparency, safety, and also patient-centered care. So thank you for having me here.
Thank you. I want to take a moment to just introduce the ex officios from the NIH. We have Michael Lauer. Michael.
Yeah, good morning. I'm Mike Lauer. I'm one of the NIH deputy directors. I cover the extramural research portfolio, and by background, I'm a cardiologist and cardiovascular epidemiologist.
Thank you. The VA, I don't see David Atkins. David, if you're here.
I don't see him either.
Okay. Oh, and did I not offer an opportunity for Kathy Ivory to introduce herself? I'm so sorry.
I think we skipped right by the eyes. Good morning. I'm Kathy Ivory. I'm Associate Nurse Executive at Vanderbilt University Medical Center in Nashville, health services researcher by background, and obstetric nurse by a clinical focused on reducing maternal morbidity and mortality. Also faculty at the School of Nursing at Vanderbilt and the Vanderbilt Department of Biomedical Informatics. Happy to be here.
Thank you, Kathy, and deep apologies. It's still early in the morning. Appreciate it. The CDC, my understanding, does not have a representative at the call today. Is that correct? I think that's the message that I got earlier. But in terms of CMS, we do have Michelle Schreiber on.
I'm Michelle Schreiber. I'm the Deputy Director of the Center for Clinical Standards and Quality and the Director of the Quality Measures and Value-Based Incentives Group. Thanks.
Thank you. A few housekeeping items. We'll go through this quickly, but it's important to remember that this is an event that's being recorded and is also going to be posted on our website once the recording is available. Closed captioning is available if you need it. It's at the bottom right icon of your screen. If you'd like, I know we've all been in Zoom land for 2.5+ years, and yet it's just in terms of centering everyone on the best processes for these meetings. If you have a comment, chat that you have a comment or you have a question, or use the raise hand function at the bottom. I will try to facilitate that as best I can. And I appreciate, as was just done, if I can't see things or if I miss something, thanks Melinda for the help in oversights, which are mine, of course. And we have unmuted all of your lines, but we just ask that you mute your lines when you're not speaking. You can change your video settings to sort of display all 49 people at the same time, which is a cool feature because there might be a lot more people joining us. And I do, speaking of people joining us, I see Henry Ting has joined us. Henry, would you mind just a quick introduction?
Hi, everyone. My name is Henry Ting. I'm a cardiologist by training. Worked as a health services researcher, as an academic cardiologist at the Mayo Clinic and New York Presbyterian, and have been recently joined Delta Airlines as their chief health officer. Been with Delta Airlines for about 1.5 years.
Great, welcome. Another important announcement is if any non-NAC member would like to make a public comment during today's meeting, please send an email no later than 12 o'clock Eastern Standard Time to National Advisory Council at arc.hhs.gov. That's National Advisory Council at arc.hhs.gov. And we do ask that you limit comments to 3 minutes or less. So our first order of business is to ask if there are any proposed changes or edits to the draft minutes from the November 17th, 2021 meeting. Does anyone have any proposed changes or edits to those minutes? If not, I would ask for a motion to approve the minutes.
So moved.
Thank you.
Kathy Ivory.
Thank you, Kathy. Is there a second?
Second.
Wonderful. So there's been a move to approve the minutes, and the AV Tech is going to open up everyone's lines. All those in favor of approving the minutes?
Aye.
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 Any opposed? Wonderful. We were able to get through our first order of business. More to come. So today's agenda you see on the screen. Again, as I said before, a lot to go through. We've gone through the first 2 bullets. We are going to hear from the new director of AHRQ, Dr. Robert Valdez, and hear about his vision for the agency, and also an opportunity for NAC members to share guidance and thoughts on opportunities for the agency, and to discuss with him and have I think an important early discussion here. I do mention that his bio will be put in the chat. It's an impressive bio, and just for time's sake, I will not go through it all, but really encourage you all, if you have not met Dr. Valdez or know him, to go through that. The second part of our work heading into the middle part of this meeting is an update and a discussion of the agency's strategic planning for investments in the Patient-Centered Outcomes Trust Fund. Look forward to that discussion. And then we'll finally end with a NAC discussion on opportunities that AHRQ has in the area of health economics and health financing research. And we'll have open public comment if there are any public comments, and then have a wrap up at the end. So barring any questions about the agenda, and again, that's the email to send to if there are any public comments, I'd like to turn over the next section of the meeting to AHRQ's director, Dr. Robert Valdez, to provide updates to the NAC.
Next slide, please. Thank you very much for this opportunity to share with you at least my vision of the Agency for Health Research and Quality, and the opportunities that I think exist, given that we're trying to recover from a pandemic that has severely stressed our healthcare system, and in particular, our healthcare professionals, and obviously created such loss in our population. Loss, not only the people who have passed away, more than 1 million, but also those who have been directly impacted through the loss of those 1 million people, and the hundreds of millions of people who have been affected indirectly. AHRQ's got a unique role and a set of authorities that Congress has given us, and that is largely to produce scientific evidence that makes healthcare all these amazing things: safer, of higher quality, more equitable, more affordable. How can any one agency do that? Well, we can only do that through partnerships, given the kinds of funding that we've received historically to pursue this particular mission. But that partnership has been leveraged with state and federal and tribal and local agencies. It's been leveraged with our government sisters and brother partner agencies, which I'll talk about in a few minutes. It's been leveraged with non-governmental groups throughout the country and our health professional associations. And where we haven't done as much, but we are clearly trying to do so, is working with the healthcare systems that exist around the country. And as the healthcare system and industry has consolidated, increasingly there's an opportunity for AHRQ to work most directly with healthcare delivery systems that exist throughout the country. Because our nation, as you well know, doesn't have a single healthcare system, but has many, many regional and local healthcare systems. And they are truly our partners and also our customers. Next slide, please. We're trying to align our work with the president and the department's priorities, and in particular, with a real focus on transforming our healthcare system for the better so that it serves everyone by dismantling structural racism and by also addressing those critical issues that are affecting our populations. And in particular, one that hasn't probably been given enough attention is long COVID or persistent COVID. That is the fact that many people who were infected by the COVID virus, particularly early on, have continued to experience symptoms and other kinds of maladies. We're also trying to expand access to high quality and affordable healthcare through really our continued work on integrating behavioral and mental health care into the healthcare system and in particular into the primary care delivery system. And we're also trying to understand the impact of climate change on the delivery of healthcare, not only on the need for facilities to be resilient to climate changes throughout the country, but also how that climate change directly impacts patient safety and patient care. Next slide, please. Well, this is a general framework that I think many of you who have worked with AHRQ has seen in the past, and that is our goals, which have largely been focused on improving the lives of patients and creating better outcomes through the care that they receive. And one of the adjustments that I've made in the first couple of months that I've been here is really to re-examine this goal and to recognize, as my guru and mentor of quality of care, Avidis Danabedian from the University, late Avidis Danabedian from the University of Michigan, recognized that it was the interaction between the patient and the health professional. And without the well-being of the health professional being part of the equation, then that interaction between the patient and the health professional could not be at its optimum. And so our goal is really not only to improve the lives of the patients, but also to enhance the working experience of health professionals in our healthcare systems. And we're doing that through health systems research, a real focus on practice improvement, and monitoring those changes in our healthcare system through the collection of data and analytics that allow us to understand where those weaknesses exist and where our work needs to be more focused. Next slide, please. Well, we obviously don't do this alone. We have great partners in our sister agencies. CDC, who focuses on the environmental issues that affect the health and well-being of our communities and have been a central player in this effort to address the pandemic as it affects the United States in particular. We've had FDA, of course, who's another of our research focused agencies that makes sure that our drugs and our devices are safe and effective for use. And of course, our big sister or big brother at NIH really focuses on that biomedical cure that we need as the base for what AHRQ ultimately does, which is focus on health care. And that care is something that is really at the base and the focus of both our authorities, but also what needs the most attention right now, given the fact that our system has been so stressed and regular routines have been disrupted, we have an unusual opportunity to actually make fundamental changes in the healthcare system and focus our efforts on healthcare improvement that's scientifically based, that allows us to disseminate the information that's been turned into knowledge and assist health professionals and healthcare systems implement those innovations so that they become innovative therapies that are available to our communities. Next slide, please. I have a simple-minded way of thinking about the US healthcare system that I want to share with you, but one I think that'll allow us to begin to think about AHRQ's role in this larger scheme. Really this focus on the patient and the health professional as being at the core. Many people talk about it as patient-centered, but as I've said, it's really this encounter, this relationship between the patient and the health professional that has to be the core. It's somewhat an evolution of the concept of patient-centeredness, but it's also a recognition that this is really an exchange. And it's an exchange of knowledge on the part of the health professional, as well as the patient's knowledge of what's affecting them and what's their burden. And in essence, what that illness burden is that they bring to the interaction. The health professional uses a variety of tools, whether it's an x-ray machine, or it's a medication, or it's the hospital facility itself, or it's the medical clinic or the nursing home, or what have you. And the consumer's behavior obviously affects this interaction. It's not only the behavior outside of this interaction, but it's also the kinds of questions that the health consumer brings into this interaction, whether they're prepared for the interaction, whether they can convey, because it's all about the communication, that exchange of information, both from the patient and from the health professional. And so I'm going to take these four pillars of the healthcare system and try to illustrate to you how I see AHRQ playing out its role in the larger healthcare system in each of these areas. Next slide, please. Now, this is a little bit of a difficult slide to follow because it's like our healthcare system, fragmented in a lot of different areas. And AHRQ really plays a role with our sister agencies in aggregating the knowledge that's developed. CDC, of course, developing our understanding of the role of the environment and culture on health burden and illness burden. NIH developing that biomedical understanding of the processes of illness and disease that comes into our training of health professionals and comes into the primary education and continuing education of our health professionals. FDA, of course, provides us with that understanding of the tools that our health professionals have to use in those interactions. SAMHSA offers the knowledge, a specialized knowledge about the mental health issues that need to be part of this knowledge of an interaction with our patients. And CMS, of course, provides us the opportunity to figure out how to deal with the financing of care, but also passes on this knowledge of how organizing care can affect the outcomes. HRSA most directly affects the kinds of facilities, the kinds of healthcare workers, the kinds of primary care that's provided in particularly low-income, disadvantaged communities. And so through that effort in the development of knowledge, AHRQ, through its work, conveys that knowledge that gets exchanged in the patient-professional interactions. Let me illustrate for you how I see this happening. Next slide, please. So for example, AHRQ's focused on improving the organization and delivery of high quality care. And we do this through a variety of ways. We build science-based tools to help make healthcare safer and more effective. Here's an example of one of our projects, Team Steps, which has been used in a variety of settings to help implement the knowledge that we have and to recognize that it's not a single professional, but it's a team of professionals, team of workers who come together with knowledge in specialized areas to make that interaction more effective, more safe. It uses the various tools in efficient ways. Next slide, please. We also try to improve the patient's experience. More recently, we've provided some really interesting tools for the patient to prepare for coming into this interaction with the health professional. I was particularly excited with this app that was developed, which is available both in English and in Spanish, that helps patients prepare the kinds of questions or to remind themselves of the questions they need to ask their health professional or the kinds of information they need to tell their health professional. When I was trying to deal with my mother's recent cancer treatment, I often had to do this with her before we went to visit her oncologist. We sat at the kitchen table. We didn't have the fancy app, but we took scraps of paper and I had asked her weeks in advance, if there are things that were bothering you, please write them down somewhere so we can remember what they are, what it is that you need to know or what you want to know. And this was a normal kind of activity that I used to do with my mother. But this is something that every patient can or should be able to do as they prepare to visit their health professional. And this app actually is one of those little devices that can make that fairly simple. Believe it or not, I finally convinced my mother in the last year of her life to get a smartphone. And so it would have been really possible for her to do this. Other than that, we just had scraps of paper all over the place and sticky notes all over the place. Anyway, next slide, please. Well, we're also in the process of providing the kinds of information through the data that we collect and the analysis that we do for understanding the financing and the coverage structures that affect the incentives for people to seek care, as well as trying to understand from an organizational management perspective what kinds of adjustments need to be made in our facilities or in our healthcare systems to actually provide the kinds of care that are innovative and that are most needed by populations. We've done this through interactions and embedding researchers in healthcare systems. And so we're calling this initiative a learning healthcare system, so that we have embedded research taking place and it's more timely, tries to address the kinds of care delivery issues that locally people are addressing, because as you know, healthcare is all local. And we've also tried to understand what's going on in the healthcare system more generally across the nation with a national healthcare quality and disparities report that we publish on an annual basis based on a number of our databases and contributions of our sister agencies with data. Next slide, please. And finally, we try to look at contributions of the biomedical sciences and convert those really from the discoveries to innovative care practices that are adopted and used on a daily basis. We do that through a number of programs right now called Evidence-Based Practice Center work. And quite honestly, they're celebrating 25 years. So I think we need to celebrate that effort because it's made major contributions to care delivery in the United States that I think often goes ignored or are unseen. Many of our sister agencies use their work. And as a result, many people think they come from our sister agencies. But in fact, it's the work that's done here at AHRQ that has made that possible. Next slide, please. Well, as I said to you, we've historically done health systems research. We've done some practice improvement focus. We've done data and analytics. But what we haven't done is really looked at the operational excellence that's required to achieve the ultimate or the best possible outcomes of that interaction between the patient and the health professional. And that can only be done by also understanding how our systems are functioning, how our individual facilities are functioning, and to really gain operational excellence in that setting. And so increasingly, I'm reaching out to the CEOs and to the board members of healthcare delivery systems to engage them in the kind of work that their departments are engaged in, to make them aware of the kinds of cultural issues such as patient safety, which is an institutional cultural issue, needs to be adopted and addressed. Next slide, please. So this is my attempt to try to bring together what we're doing here at AHRQ, or how I see us working at AHRQ. The center circle is that work that we've been doing, looking at the primary research that's necessary to improve healthcare practices. But on the outer ring are really that issue around where that healthcare practice operates, the healthcare systems, what we need to understand about decision support systems that assist the delivery of care. It's about understanding how to use new analytics to understand and gain new knowledge in the care delivery arena. Next slide, please. Well, let me just briefly say that the president has put forward a fiscal year 23 budget that suggests that the Congress fund us at about $416 million in discretionary funds. That would be a 19% increase from our enacted 22 fiscal year. And in addition, we're slated to receive about $110 or $111 million from the Patient-Centered Outcomes Research Trust Fund, which will be the focus of part of our discussion this afternoon about what's the most strategic way to begin to use those funds to improve healthcare by the dissemination and implementation of the findings of the research that's funded by PCORI. Next slide, please. Our proposed budget for 23 includes a couple of new initiatives or new investments. One has to do with this issue of long COVID care. It's a start, 19 million. Clearly, the extent of the potential issues and problems that we're likely to face could clearly use more, but we'll at least have an opportunity to begin to define what that care should look like and how it can be organized and delivered. We're also talking about a $5 million investment in the development of a national all-payer claims database that isn't the collection of claims for all the country, for the entire country, but it is an effort to work with the states to provide them a benchmark for understanding their all-payer claim system, and also to plug up some gaps in their data to understand better in each of the states how payers are operating, what the demand is for care. But it also allows us to synthetically look at all payers in the country and provide additional support for the kinds of financing questions that national and federal health policymakers need to answer. There are also a couple of other initiatives, a focus on telehealth care implementation, as well as an initiative that's focused on maternal health care within AHRQ. That's really about the patient experience. It's about understanding and developing more data to really monitor the maternal health care experience. Next slide, please. Well, just some final comments before we begin this discussion, and that is, I've made some initial changes in the way we think about our mission, and that is to refocus our agency on that patient professional dyad. So I'd really love to know what you think about this and whether or not that's a focus that really I should continue. The other is to really emphasize how we generate knowledge and implement knowledge so that, in fact, that knowledge isn't just publications, but it becomes implemented new therapies in our clinics, in our hospitals, in our nursing homes. I think there's a great opportunity and potentially we're missing an opportunity to make some fundamental changes in the healthcare delivery in our country that the pandemic has actually provided the opportunity. You know, with every disaster, there's always a silver lining, and I'm a very optimistic person, and I'm always looking for that opportunity. And I think we have that now. And I think we need to cultivate the relationships with our healthcare systems leaders and their governance boards. We really need to make AHRQ to healthcare systems what CDC is to the local and state public health systems. And to do that, I think it's extremely important for us to recognize that the pandemic has really stressed our health professionals and our patients, so much so that patient safety has been affected as a result of the pandemic. Central line, for an example, central line bloodstream infections, which we were doing great reducing. The 5 years prior to the pandemic, we had reduced it by about 32%. During the pandemic, however, central line infections have risen about 28%, virtually wiping out all the patient safety success that we had in the prior 5 years. But we can't continue that way. We've really got to take advantage and refocus our efforts to try to improve the care and the safety, not only for our patients, but also for our healthcare professionals who've had a huge number of issues to deal with. PPE, lack of PPE, the difficulty of using PPE. Personal experiences at the University of New Mexico with my colleagues who've had to leave their normal clinic activities during waves and return to the hospital setting. Some who haven't practiced in a hospital setting in 30 years. It's a completely different place. We are a very sort of primary care focused delivery system. So it's that opportunity to try to really rethink and reorganize our care and delivery so that it's safe both for health professionals, but also for our patients, and especially for our patients. We need to expand our professional relationships within AHRQ. We've become very physician-centered and focused, and we need to include more of the perspectives that nursing, pharmacy, allied health, and even our non-clinical staff who are central to the delivery of healthcare can bring to our understanding of the issues and concerns. We need to re-engage our social and behavioral scientists, because what we're really truly interested in is systems change. And we're interested in how we can better help health professionals implement new knowledge. And that's the kind of work that our social and behavioral scientists focus on. So we need to re-engage that notion of an interdisciplinary science of health services research. And lastly, not lastly, but probably more importantly, we need to support patients in their care delivery experience. We need to understand it. We need to understand the issues that are affecting them so that we can work with healthcare systems and leaders to improve that experience, not only at the clinical level, but also in the non-clinical experience, because it's that total experience that we really need to focus on. It's only in that total experience that we actually have an understanding that we're succeeding in what we're trying to do, which is to improve the lives of our patients, as well as creating an excellent work environment for our health professionals and the people who actually provide care in our nation. So I'm sure I've said a number of things that are controversial, that press some current concepts. And so this is an opportunity for us to talk about that.
Wonderful. Well, thank you so much, Dr. Valdez. I see already that we have some hands raised. First, my phone.
Morning, and congratulations, Dr. Valdez. What a wonderful seat and just the right person to land in it, I think. I want to congratulate you on having built out such a cohesive vision and one that I think really leverages AHRQ's roots, but reveals, your focus on this holistic approach to healthcare. I would just strongly recommend that AHRQ walk into this work with humility about the reach of healthcare services on a person's health. I think that we are all familiar with data about the predictive value of social circumstances and economic circumstances on a patient's health, as opposed to the illness care that they receive, and even the preventive services that they get within the healthcare system. And so from that perspective, I think there are opportunities perhaps to nuance a number of these ideas. For example, when you talk about the well-being of the professional, I think to not acknowledge that broader realm of socioeconomic impacts sets the professional up for a sense of failure, because it expects the professional to achieve all of that within the purview of their four walls, as opposed to finding partners outside of the office who can help affect some of those socioeconomic inputs to health. So that, I think that's one consideration. And I would venture to say that that's a key component of primary care burnout, for example, is feeling that you haven't managed to solve your patient's problems when they come in the door. I think another nuance that this implies is that when you think about deepening relationships with health system leaders, I would just, and I see several health economists in the Zoom here, I would just caution that you want to posture AHRQ, I think, in a way that doesn't have you captured by the needs and interests of the health systems, because while they make really important contributions, they also are extremely adept at soaking up resources that can go somewhere else, for example, toward addressing some of those upstream inputs. And so I think that there's a nuance there. And then when I think I know we haven't talked about data and data investments and research investments yet, but when I think about the circles of potential new partners, I think about the giant elephant in the room, which is home and community-based services. Now that's partly with my Medicare and disability hats on, but we have a decade-old projection from Karen Davis that if we were to meet, and this is from 10 years ago, if we were to meet all the unmet need in home community-based services, we'd be talking $3 to $5 trillion every 10 years. Now that is work that a clinician cannot do. And again, it contributes to a sense of failure when the country and AHRQ in its understanding of the health system doesn't take into account what are the best practices in that sector, what are the resources that sector needs, how should that sector interact with the clinical sector, if we are to call HCBS a part of the healthcare system. And then I think the broadest view in terms of data is if you take this socioeconomic perspective, knowing that it's going to add tremendously to the predictive power of whatever guesses we're going to make about a person's needs. I think that AHRQ has an opportunity here, and I realize, David, that I'm starting to sound like a broken record, but there is a lot of data that is proprietary that is now a commodity. There's no reason that AHRQ can't have proprietary data, and not only the raw data, but the analytic work that has already been done in public and private sectors on organizing that data into socioeconomic indices that have been proven to be predictive of healthcare spending and outcomes. And I think the opportunity to link that data to any number of AHRQ's current data sources to just enrich that view and remind us all that while we are very influential, we are but 10 to 15% of the predictive value of what will happen to that person's mortality and morbidity. Anyway, so I'll hop off my soapbox, but hoping to just inject a little bit of—
Don't hop off, don't hop off. The fact is, I had to resign as the chair of the Foster G. McGaw Prize, which has for the last 35, 40 years attempted to do exactly what you were suggesting, which is to help the hospitals in particular, hospitals and healthcare systems, get outside of their four walls, to actually recognize that only through their partnerships with the social service agencies in their communities could they in fact assist their clinical professionals do their job and also feel more accomplished. And I invite you to look at the Foster G. McGaw Prize examples on the American Hospital Association website. And you'd be amazed at the kind of work that people are now finally, after 30 years of hearing me nag and my colleagues nag, all the same things that you were talking about on your soapbox about the need to really connect with our local community service providers that are outside of the healthcare delivery system, but are essential to the success of our healthcare delivery. I think you'd be amazed at I have to tell you, when I do site visits of these places for the prize, my heart and my soul is just fed by the dedication, not only of the healthcare delivery people, but of the social service delivery people. And I think what we forget sometimes is that we're the Department of Health and Human Services. And so in the month or so that I've been on the job, I've in fact reached out to ACL, which is the Agency for Community Living, who has their own separate little research organization within it, and to look at how AHRQ and that research agency, in fact, can do work that's complementary and that addresses those issues that you brought to our table today. I think if we don't do that, then we've missed all of the rhetoric that we talk about going upstream, and we're still focusing on putting the Band-Aids on without dealing with fundamental reasons that the illness burden finds its way into the lives of patients and then patients seeking care. So I absolutely agree with you. And that's part of why that one sector or those two sectors of this pillar that or these four pillars that I showed you is really focused on those issues of patient behavior or consumer behavior, because that's dictated, if you'll look at that little chart, by the resources they have available to them, whether it's money, whether it's other kinds of services. And that comes into our interaction with the patient. And it's not something that we have direct control over, but it's something that we can partner with our human service agencies to address and deal with. Maslow had his points. Unless we deal with the housing, unless we deal with the food, unless we deal with sort of the basic needs, we're not going to get anywhere. And all of our efforts in the healthcare delivery system will be wasted.
Susan Edgman-Levitan.
Yes, hi. I want to add my welcome and congratulations to Mize. And I have two questions. One is, I'm very curious about your thinking about what AHRQ's role would be with the outreach to health systems. I think I have the same concern that Mai has about capture. And I'm very curious, given the number of international, national, and regional entities that are really focusing on patient-centered improvements, safety improvements, et cetera, sort of what your thinking is about the role that AHRQ will play there. And my second question is I'd love to hear a little bit more about what the focus on maternal health care might be, because that's critically important, and that's actually something the CAPS team is really thinking hard about. So I'd love to sort of hear a little bit more about that, if possible.
Well, let me start with that actually first, because it's a presidential priority that's been found in departmental priority that's found its way into our fiscal 23 budget request. And for AHRQ, the department and its agencies are engaged in a variety of different initiatives. At AHRQ, it really is a recognition that our patient experience data and our ability to monitor what's going on in maternal care is very weak. And so these funds would allow us to begin to supplement our ongoing surveys, both MEPS and others, to really provide us with a better view of what's going on in maternal care. Quite honestly, in my own training, the degree of mortality that we've seen, maternal mortality, really reflects a systems failure, not the failure that people seem to be focusing on, which is on the patient and their sort of environmental issues. Historically, at least in the international or global health world, that kind of maternal mortality measure was a clear signal that the system itself was failing. And unless we begin to understand where that system failure is taking place and how we can address it, it's going to be very difficult for us just to throw money at more care services. As some of my colleagues who know me, they know that I for the longest time have said throwing more money at more care doesn't get us more health. And we really need to understand the underlying reasons for the illness burden, and also drive our solutions so that we're in fact doing things that are effective, not only for the patient, but efficient for our system delivery. With regard to the capture, yeah, anytime you work with industry, there's the possibility that government agencies could be captured by the industry that they're working with. That's particularly true of regulatory agencies. We're not a regulatory agency, but we do produce a variety of tools and frameworks that we want health systems to adopt. We want them to use to make care better. And in many ways, my perception of the healthcare delivery system leaders and their governance is really more as potential customers that we ought to be reaching out to. Not so much where we're going to be captured by them as much as we do need to know what our consumers want to buy, what they buy, in the sense that in the government, it's public domain, so they can run off with it and actually put their label on it and sell it, and make some money. And we see that all the time. But I don't particularly see that kind of relationship as a regulatory agency industry capture issue. For me, if we get captured in the sense that they're telling me what they need and want, that's actually what I want. I want to know what they need and want, or what they think they need and want, so that I can potentially convince them they need and want something else.
Well, I think I'll just make a quick comment. I think that's actually in line with the SNAC that looked at what AHRQ's role would be in quality measurement, is really getting input from health systems and other people about what will be most valuable to them. So thank you.
Thanks so much. Melinda Bunton.
Hi, I was worried that my comments would sort of sound like skunk at the garden party, but the conversation has gone a little bit in the direction that I was hoping to send it, which is that when I saw your final thoughts, Bob, both the first bullet and the last bullet sort of gave me pause, because what I think AHRQ has really been excellent at is taking a systems view. And so focusing only or increasingly on that patient provider or patient professional dyad, I think would be a mistake. I think that AHRQ uniquely contributes to taking a systems view of how to improve healthcare delivery. And then while I also agree with many of the things people have said about the true determinants of health, I do think that while AHRQ is part of the Department of Health and Human Services, AHRQ is the Agency for Health Care Research and Quality. And it's a small agency with a limited budget. And so I think that making sure it's executing on its core mission and addressing the just manifest problems that we have with healthcare systems and healthcare delivery and quality, really broadly, not narrowly, is really important for the future of the agency. And I hope you could hear that, because I just got a message that my internet was unstable again.
Yeah, it is. I heard you, and I did not. While I suggested that we look at what's at the center of that system, I in no way meant to suggest that we should get away from our systemic or systems view of delivery. In fact, that's what that larger bubble was about. It was really about the fact that while we've been doing much of the work of AHRQ has been focused on that sort of patient-centered care, and it's been doing it in a systems focus. It's really understanding that context of where that care takes place, but it's also a recognition that it's not just the patient. It's the patient and how that patient interacts and communicates with the care provider that needs to be part of that systematic view of the world. Once we recognize that it's dyad, then that systems dimension actually widens. It doesn't narrow. In fact, at least in my formulation, it becomes a much broader set of discussions and opportunities to look at systems issues. The concern about getting away from our focus has become almost exclusively on that sort of technical aspect of what is the new knowledge and what is the new knowledge that should be available. And what I'm trying to do is really recognize that we need to not only understand what the new evidence is that should be transmitted, but how do we in fact transmit it in a way that's efficiently and most effectively adopted, so that it doesn't take 10, 15, 20 years for an innovation to find its way into regular clinical care. We've spent a lot of time on the front end. We've spent less time on the back end of how do we actually take those discoveries that are biomedical, turn them into actual practices that could be adopted, and actually moving from there into the adoption and the use of those practices. And that's a systems issue as well. And that's what I'm trying to point out with this, because unless you've set up the system so that you can deliver the kinds of innovative therapies that are available, unless management decides that they're going to create the space for the new machine or the new procedures or the new constellation of care providers, then we don't have a receptive location for that care to actually be provided. So I'm not at all saying that we move away from our systems approach. What I'm saying is that we need to think about it in a more complex and full way.
Thanks. Joe Brown Spikes.
Hi, thanks so much for the opportunity. And I just wanted to say congratulations again, Dr. Valdez. I really appreciate your comments and kind of the things that you're talking about, even including your most recent comments. So I feel like some of the questions that I have you answered in those last comments there, but I'll just at least make the point that I do agree with your focus on maternal health and kind of going in line with the president's priorities there. I think even your specific questions or comments around, that maternal health and that issue being a systems failure, and can we pay attention to or investigate where that failure is occurring, especially as it relates to, really increasing disparities in that space is very important. So thank you so much for that. I did have comments about the patient provider health or patient healthcare professional dyad and what that would mean. So I think your systems comments were really well placed there. Dealing with thinking of it from two standpoints, like the health equity standpoint for patients, and then also thinking of it from, the physician well-being standpoint. Both of those are systems issues. And so much of the time they end up being, we focus a lot at the individual level, and we still continue to be in a cycle of either, increasing disparities for the patient or physician burnout. And with physician suicide being at, like almost one physician or a little more per day, I think it's something that we have to be really careful about when we talk about focusing in on that dyad and what that means, because I wouldn't want that to lose the focus that we need to have on physician well-being, which is a systems issue. And so I just kind of wanted to kind of bring that up as a question and see what you really had envisioned when you talk about reimagining or sort of re-engaging that dyad. Definitely think it's important. Person-centered care is extremely important. And I love the concept of, how do you look at that team and that unit together, but definitely wouldn't want it to, adversely affect the individual level bias that could potentially happen for the patients, and also not pay attention to the impact that it might have worsening physician well-being and really thinking about that from a system standpoint. And I'll also just comment that there's a lot of bias even within our systems as we're trying to address some of the wellness issues. And how do we, from a systems level, really top down, begin to make that a better space for our providers, especially as it relates to healthcare delivery and the burdens that are contributing to that burnout. The other thing that I'll say about that is workforce. So even trying to fix this, I feel like we have a workforce issue as it relates to contributing to this situation as well. So thank you so much for the opportunity. Oh, sorry, one last thing I wanted to comment on is community engagement. So as we think from a systems level, I think it was Maya, I believe, who talked about just kind of human services, but I was thinking even like, around community engagement and how can engaging the community in healthcare delivery really improve the patient experience and improve the quality of care and the health outcomes for our nation. Thank you.
Well, thanks for your comments and your kind remarks. Yes, as I've been thinking about this actually is something that when I'm talking about this dyad, it's really about recognizing that the way we've conceptualized patient-centered care is such an American thing. It's such an individualized perception concept of the patient and who's actually experiencing the illness and disease. And quite honestly, as a pediatric researcher, I have to tell you that the one publication that I did early in my career that's gotten the most requests for copies internationally was one that was done on, you want to guess what the topic is? Bedwetting.
Bedwetting?
Bedwetting. So, this is an issue that affects many, many people because of the space in which they live and the effect that it has on all the other members of the family. So, if we only think of the individual as the patient and the provider as the only individual that can do something, then we've missed the equation. Because, and particularly in an aging population, that patient is really a patient team. And that health professional is, if we're doing things right, is also a team. And so not everything falls on one individual and the other individual. But in fact, we need to understand that when we're dealing with a patient, we're not only dealing with the patient, but we are dealing with the patient and their family or their neighbor or their caregiver. And we're also dealing with, on the health side, a team of health professionals, so that not everything falls on one individual, not the entire responsibility of success and failure in that interaction falls on one individual. There's no question that the work environment and the demands that have been placed on health professionals has increased the stress. I can tell you from a personal experience at the University of New Mexico, when my colleagues in family and community medicine, because of the wave of the pandemic, had to find their way into the hospital because we were running at 150, 180% of our capacity. They were completely stressed out. They often went days and weeks without real breaks. There were times they didn't see their families for days on end. And on the other end, those of us who had non-clinical responsibilities were picking up all the non-clinical activities of a medical college, medical university. So I was teaching, I was already retired. I was teaching a heck load of all these other courses for the first and second year medical students because my colleagues were tied up in the clinic or in the hospital. And so, the normal routines were just completely destroyed. And the stress didn't resolve itself when that wave came down. What happened? Most of you who are in clinical practice know, we still had the rush of all the pent-up demand that got put off when we had the COVID waves. So there was no rest. We've had no rest. It's been crazy, and it still is. So I completely understand, but what I'm trying to get at is really a recognition that this notion that there's a patient and we're patient-centered, but somehow the care provider isn't in the equation, doesn't recognize the fact that if the well-being of that health professional isn't maintained, then the interaction, the ability to take that knowledge that we've helped them acquire and through this knowledge generation that AHRQ engages in, gets lost for fatigue, for the lack of equipment, whatever it happens to be. So I completely understand, and that's kind of the reason I'm bringing this to the attention, that we need to think about not only now and the individual patient, but in an aging society, the fact that many of our patients, in fact, are going to be not there by themselves. When I took my mother to her oncologist, she wasn't going to the oncologist alone. If I wasn't taking her, it was her caregiver who most of the time was with her, because I lived in Albuquerque, my mother lived in San Antonio. Most of the ongoing care monitoring activities I did electronically this way or by smartphone. So we're dealing with a different world. We have to figure out how we operate in this different environment, because it's not going to go away. We're not going back to the old normal. We've got to create a better new normal.
Thanks, Kathy Ivory.
Hi, thank you. Welcome, Dr. Valdez. I was very excited to see your focus in new directions. I have a couple of comments, and I'll end with a question. So related to maternal health and systemic issues, completely agree that that systemic problems are at the root of maternal outcomes. What I haven't heard mentioned yet that I think is extremely important is the issue of systemic racism as it relates to systemic failures in maternal care, specifically with the overwhelmingly higher rates of poor outcomes for people of color. And I know that's a priority of AHRQ already, is mitigating racism. Also want to go then to the focus on implementing the evidence, and the evidence is pretty clear that as we think about maternal outcomes, we need to think about the things such as birth setting and birth provider, which relates to your increased focus on the involving of other professions. As we know, both related to primary care and maternity care, the best care providers for normal people may be advanced practice nurses and midwives. And so how do we get a sense really looking at research that further contributes to that body of evidence? I loved your idea about involving all members of the healthcare team. We know that we have a healthcare workforce that's in crisis post-pandemic, and we are all in health systems going to need to be thinking about different models of care that involve physicians, advanced practice nurses, PAs, pharmacists, allied health professionals, and all of these very important members of the care team are very much attributable to outcomes, but we need to be able to attribute their contribution to the care team. And so that leads me to the need for data standardization and the ability to uniquely identify those individuals, which has not been easy so far. And as we think about, data and what data we need to make those decisions, I want to call out that. I also want to, you mentioned specifically that as the COVID pandemic raged, we had increased rates again of things like bloodstream infections and CAUTIs and CLABSIs and pressure injuries, and all of us closer to the bedside are really focused on that, which has me calling out the need to think about our healthcare resources as therapies and not necessarily direct costs. So, was it the fact that we didn't have an appropriate dose of nursing, for example, that allowed us to maintain the levels of intervention that are so necessary for good patient outcomes. So just a different way to think about how we consider the contributions of the workforce. And finally, that leads me to what I saw missing from several of your graphs, and that was the contribution and importance of the Office of the National Coordinator for Health IT, who is the office that is so associated with setting IT standards that if we potentially implement them, we may be able to get a better handle on both the interventions that lead to the best outcomes and the attribution of the care providers that contribute to those outcomes. So thank you.
Yes, thanks. That's a great observation. Yesterday, actually, we were talking about the fact that so much of the new diagnostics is increasingly digital diagnostics, and the use of apps by different people to take advantage of technology's ability to sort of substitute for the fact that we're short of health professionals in so many areas, particularly in rural communities where mental health professionals are hard to be found. So I appreciate that recognition of the gap in that sort of strange effort for me to try to sort of describe the U.S. healthcare system and the unique role and contribution of AHRQ in conveying knowledge to the health professionals and patients.
So I'm going to take the chair's prerogative to continue this very rich discussion for a few more minutes to make sure that we get to all the questions arrayed here. I am going to ask, and David asks as well, to really choose parsimonious brilliance, the briefest, most to the point question, as well as Dr. Valdez, your answer, so that we can in the speed round get as many of the questions answered. So Murray Jacobson, thank you.
Yeah, just echo the welcome and congratulations, and just want to say that the one thing I've heard really missing in the discussion, but that I think is so central to both the patient experience and I suspect also the provider experience, is insurance and payment and benefit design. And a lot of what the patient experiences is not just the healthcare, but trying to understand what it is that they can get, when and how. And I just wanted to just make the point that I hope that will continue to be part of the discussion, whether we like it or not. It's inevitable. So thank you.
Well, as you know, that's my own area of research and work. So I didn't say much about it now because we have an entire period later on in which we're going to be talking about health economics and health financing research at AHRQ.
So it sounds like still a big priority as our next comment, our session in the middle will talk about. Yanling Yu.
Yes, thank you. And Dr. Valdez, congratulations again. I really like your point. You pointed this, make the new vision about patient-centered care. I taught team STEP several years, AHRQ's team STEP at the University of Washington. So I fully appreciated how the care is really, it's not just a single person, it's really a team with a community, care providers, and also family. So I really appreciated your vision on that. And, also the healthcare, it has a different modes. There's a failure mode, every system like that. And we see in the COVID, the pandemic, and we have many failures in this healthcare system, like the increasing infection of increase, and basically wrapped out our progress over the year. So I hope the AHRQ would help building the research and the new vision to make this healthcare have a better way to address this failure mode to make it safer to everyone. And the safe care safety is really affect the healthcare cost and also the patient, definitely, and also the community, family around the patient and the healthcare providers. So I don't know if you did for intentionally what you first slide, you have a make healthcare safer. The safer is right on top of the list. So I really like that because safety, you have to have a safety first when you try to talk about equity and expanding the cost of the healthcare to everyone. And also when we talk about making patients more centered care, we also need to make them more informed. Being informed, I mean, we need to make our, example is the HCUP. This database is actually have all kind of information on healthcare use, access, outcome, and the cost. And maybe later I'll make comments that we should make those type of data more transparent and also more accessible to healthcare consumers, so they can make an informed decision, so that you have a better experience in healthcare. That's basically my comments. So anyway, so
thank you very much. I appreciate your recognition that AHRQ in fact has helped develop a national plan that's ready to be put in place, to be initiated. And part of my outreach to the health plan leadership is really to have them buy on to this national health plan that's focused on patient safety and really recognizes that it's institutional culture that's at the foundation of trying to make healthcare delivery not only safer, but better.
Thank you.
Omar Latif.
Thanks, Dr. Baton, and congratulations, Dr. Valdez. And it's great to sort of meet you. And I look forward to the day where we can sit in a room and have a conversation. I think that'll change the environment and make it more interactive. I have just a very quick comment and then a question. My comment is on the systemization of view is critically important. And, we alluded to quality and we used words like failure and dropping back. And I think there's many different organizations that measure quality for the United States government. AHRQ has a tremendous amount of skill set and knowledge in this area. And there's a lack of uniformity in many of the measurements and a lack of different definitions, even when it pertains to social inequities as it ties to quality. And so if added to a lot of what we talked about is helping with that standardization, using the influence that you have, Dr. Valdez, or any of us have, so that we can say to the healthcare community at large, this is how we're measuring in a standardized way, in a uniform way that would remove an incredible burden on healthcare providers across the country and allow us to know if what we're measuring is what we're hoping to measure. And I think that we're in an environment right now coming out of COVID where people are not just burned out, but we are defensive. And the setting of saying there's a lot more bloodstream infections, it's relative to a non-COVID period. So the environment of healthcare over the last 2 years is very different than the environment of healthcare for the 2 years prior to that we're comparing our end to. And so having 14 ECMO patients with non-attributable fevers because of the pandemic, calling it a line infection and then having them in a unit for 200 days, in and of itself will increase a 40% change in your bloodstream infections. And what's concerning to me is if one group in the government recognizes that and another group does, and a third group buys that data and uses it for their rankings, and a fourth group does this, I see this and wondering your opinion, is this an opportunity for AHRQ to help standardize from a system approach how we use these definitions and then use their influence across the rest of the government organizations as an academic body without any alternative other motives to standardize that approach?
Given that I was asked to be short, the answer is yes. I think there is an opportunity.
It's good enough for me.
But the issue is also just to get people to understand that the whole terms of health equity and all these other health disparities and social determinants of health people are using in a variety of different ways, and that standardization needs to be taken into account too, so that we're all trying to achieve the same goals. And that part of that is really clarifying and standardizing what we're trying to accomplish and what we're trying to measure. I completely agree with you, and the environment's changed, the environment's different. The endpoints have been measured in different ways and have been used for different purposes.
Fewer, better, simpler measures that are equitable for all. That seems like a great priority scheme for a big part of the work. It sounds like a number of members are saying. David Schmitz, and then we have one quick question from that we've received.
Thank you. And again, welcome to your new role and congratulations. I'd like to also just present a challenge I'm hoping that we can grapple with, and that has to do with AHRQ's role in quality measurement, and in particular, the attention to system failure. One of the things that I've found is really difficult to assess in quality is access to care and its impact, which is particularly applicable to rural areas and rural healthcare. And I do think maternity care in rural areas is a particularly good example of this. In my experience with quality, it seems that data tends to be collected where care is delivered. And it takes an additional effort and an additional second layer analysis to measure outcomes that were due to lack of access to care where care did not occur, or maybe could have or should have occurred. And I think of, for example, critical access hospitals delivering babies, whether or not they intend to deliver babies, or being the best access to care in some rural and remote areas. And so I think that this is a particularly good time to have a discussion around how to analyze quality and how it applies to the unintended consequences that can occur in low resource environments, such as rural and remote areas, because we have maternity care target areas that have been defined and are part of our workforce strategy. But this is going to take coordination both among and between healthcare systems. And a different analysis technique with regard to looking at those outcomes. And I think we've done this before. When we look at trauma systems, trauma care systems, for example, often developed on a statewide basis, we've been able to do that. And I think there really is a golden hour of maternity care with regard to both maternal and neonatal outcomes. And what I'd really like to see is that we can begin to look at the fact that we don't want to miss out on that analysis, because deliveries are not going to be delivered by telemedicine. And so making sure that we have the folks with the hands-on skills, even if they're, again, not delivering babies as a routine, that they at least can manage some of those relatively simple and supported perhaps by telemedicine clinical care scenarios that are urgent or emergent and can really preserve life and better health.
Thank you for pointing out an extremely important issue, and I look forward to other members of the NAC helping us think through this issue, because it's a complex one, and it's one that I'm really glad that you've volunteered the rest of the NAC to engage in. And we'll have an opportunity to talk a little bit more this afternoon about those new directions and those new areas, not only of data collection and the type of data collection, but also the kind of analytic developments that we need to invest in. In many ways, we're still relying on old methods and old survey approaches. Not that they're not good, not that they're not useful, but we're in a new environment. We have a new set of sources for data. We have new opportunities for ways of looking at and understanding data. So thank you for bringing that to our attention.
Wonderful. Dr. Valdez.
I believe I see Dr. Arbach just joined us. So I thought you might want
I've
to
been lurking. I just want to jump in before I have to go back on around. Just want to say welcome and thank you for your service, and looking forward to seeing everyone in July. This was scheduled when I was on service, and I had a little good time this morning.
Thank you for jumping on.
And one last very brief question. As we were discussing, it's clear that across NIH and other parts of HHS, data science, informatics, AI are becoming integrated in across these agencies and funding platforms. What's the directional plan to make informatics, AI, data science, integrate into the lifeblood of AHRQ?
Well, I think that's the discussion that we're having now. Part of it is how do we re-examine where we're investing our data resources and our data analytics. And it's something that we desperately need to hear from you, where we ought to be going, where we ought to be investing, and where is it our comparative advantage compared to our sister agencies of what makes sense for the role and mission of AHRQ.
Thank you so much, and completely agree. Well, we will continue these rich conversations. Dr. Aldez, I just wanted to thank you for your presentation and for the time you spent answering these questions, engaging this wonderful conversation, first of many, we hope, and thank all of the panelists as well. We are going to move on to our next session with Dr. Karen Rhodes, who is the Chief Implementation Officer in the Office of the Director of AHRQ, and we're going to be talking, sorry, one second here. We're going to be talking about the Patient-Centered Outcomes Research Trust Fund, and then take some questions and have a discussion at the end of Dr. Rhodes' presentation. So Dr. Rhodes, please.
Dr. Rhodes, you're on mute.
Of course I am. I'm honored to be able to stimulate the discussion around AHRQ's P-Core Trust Fund investments. Next slide. Oh, yeah, there you go. So today I'm going to give a little background about the P-Core Trust Fund mandate and discuss our strategic planning process to date, our goals and processes, and the proposed strategic framework we've developed, and our plan for public and external input. But the vast part of this session is to really let you guys have a discussion about your charge to the subcommittee of the National Advisory Council. For those of you who were here over a year ago, this NAC recommended setting up the subcommittee. And thank you in advance for that recommendation, and I'll tell you where we are, and then ask you how this subcommittee can be most helpful to the NAC. Next slide, please. So the Patient-Centered Outcomes Research Trust Fund was established by the Accountable Care Act in 2010 and authorized 10 years of funding. It's paid for by a tax on insurers. And the funds are split by formula, with 80% going to PCORI, the Patient-Centered Outcomes Research Institute, to conduct comparative effectiveness research. AHRQ gets 16% to work on disseminating that research, but also other governmental evidence to improve healthcare and the way healthcare is delivered. ASPE, the Assistant Secretary for Preparedness and Evaluation, gets 4% to help build the P-Core data infrastructure. Next slide. So from the beginning, AHRQ's role in disseminating evidence-based findings has been interpreted to include synthesis of the evidence, translation and communication of the evidence, and implementation to include the use of digital tools, other tools like team steps, and clinical decision support in order to get evidence into clinical practice. Our second mandate is really to train the next generation of health services researchers and build the future capacity for patient-centered outcomes research. Next slide. So, I should add that AHRQ's P-Core Trust Fund Authority does not by itself include doing research, but we are expected to evaluate the results of our dissemination, implementation, and training efforts. So within the reauthorization of the PCORI for an additional 10 years, AHRQ anticipates receiving approximately $1 billion over the next 10 years to support our work. But the funding formula remains the same and the charge to AHRQ remains the same. Although I will say that with reauthorization, PCORI is expected to definitely take on research related to a wider variety of outcomes, patient-centered outcomes, including costs. But this $1 billion over a long period of time is important because congressional authorization funds have to be spent within the fiscal year, which is always very challenging. But P-Core Trust Fund dollars can be rolled over and can be used over a longer period of time, which presents a great opportunity for long-term strategic planning. So next slide. So, and next slide, yes. So the goals of our strategic planning are to create a strategic framework, ensure appropriate stakeholder engagement, invest in necessary infrastructure here at AHRQ to support this work, and to design an evaluation. Next. So what's a strategic framework? It defines a clear goal. It describes the necessary components to achieving the goal and identifies areas for focus. It basically includes and states achievable sub-goals that are necessary, but not necessarily sufficient to meeting the overall goal, and allows the majority of projects to be connected both to the components and to each other. And it also provides an outline for creating an evaluation framework and measuring success. Next. So we convened a cross-AHRQ staff level strategic planning committee and iteratively decided on our mission, vision, and goals going forward for the next 10 years. And our mission is consistent with our congressional authorization, which is to synthesize and support the dissemination of evidence into practice and train the next generation of patient-centered outcomes researchers. We spent a great deal of time on our vision and settled on empower equitable whole person care across the lifespan. Our overall goal then is to improve health outcomes by promoting high value, safe, evidence-based, integrated, coordinated, team-based, patient-centered care with a focus on underserved communities. Next. So we looked at the last 10 years of our investments and the both AHRQ's overall goal of improving the way healthcare is delivered and the administration and HHS priorities, and honed down on a smaller subset of priority areas that will guide our investments going forward. And these are health equity, prevention, and improved care of people with chronic conditions, promoting patient, family, and provider experience of care that enhances trust in the healthcare system. And high quality, safe care that's aligned with national priorities, which may change over time. And transformation of primary care to include new models of care and behavioral health integration and recognition and involvement of social determinants. For each of these priority areas, the next slide, we identified several desired outcomes. And I'm not going to read through them all because these might change, because right now we are currently considering this a proposed framework and proposed outcomes that we'd like to see as we gather external and public input and subject matter expertise. So this slide represents the framework that we're proposing, and the next slide has where, next slide, please. This is the website where you can learn more about what we did the first 10 years, which was really good, and where we hope to build on that and do more for the next 10 years. And this is also includes a link to our Federal Register notice. Next slide. Next slide. There you go. So we have this, I mentioned our Federal Register notice, which anyone can go to. And we're dropping that link in the chat so you can grab it and go right and make public comments for those of who are online. Though we are taking public input on the Federal Register notice, and we have specific questions for the public. And that notice closes on May 24th, 2022. So in addition, we are working really, I think we have a new perspective on our need to coordinate with the Patient-Centered Outcomes Research Institute and with ASPE so that we can leverage our authorities and our overlapping authorities and work together to coordinate and align our efforts so as to have greater impact with the PCOR Trust Fund dollars. And in addition, we have 4 public workshops through the National Academy that will happen June and July. And most important to this discussion is input from the National Advisory Council's Subcommittee and that the very first meeting starts June 22nd, but ongoing work is happening in advance of that. So our overall goal is to integrate all this feedback and finalize at least this stage of our strategic plan by the end of the year. Next slide. So we're going to focus on the charge for the snack and tell you about the people who are involved and what we've envisioned the role, but we're actually turning this back to you and with questions for discussion. We have recruited an incredible group of folks to serve on the snack, including, next slide. The top 2 are Myrelle Jacobson and my fam, who are your own members who will weigh in and represent the NAC on the snack. And we really appreciate this additional service. We have also recruited 12 additional people. And in the interest of time and leaving more time for discussion, I am not going to, next slide, go through all of their bios. However, you have them in your board, next slide, please, in the board materials, and we can put their bios along with the recording of this meeting on AHRQ's website. So they really are an incredible group of folks, very diverse, deep expertise across a number of our authorizations and also in our priority areas. So we are excited about them and really interested in gaining their input into how we can have the most impact with AHRQ's portion of the P-Core Trust Fund. So next. Oh, I should mention that the SNAC members who are not NAC members are, many of them will be online and listening to your input, by the way. So myself and Elena Fournier are going to help with coordinating, and we're very lucky to have Kristen Dillon, who is going to facilitate the SNAC and help synthesize input. And her bio is also included. She's going to do an amazing job. She has deep expertise in the local, state, and federal health policy, and most recently worked with the governor of Oregon on the COVID response for the past few years. So now I want to go to the charge for the SNAC. Next, yeah, there. So as we put this together, we viewed that the SNAC would basically, their role of a subcommittee is to provide input to the NAC. We're figuring they'll weigh in on our strategic framework and how we can develop a really connected portfolio that responds to the priorities, both the national ones and the ones that we've laid out, and help us think through specific objectives and metrics and strategies to achieve and measure success. We look forward to hearing the SNAC and all of your ideas about innovative approaches and methods so we can increase the impact of our dissemination, implementation, and training activities. And thinking deeply about key stakeholders and partners and partnerships, both on the federal, local, state, academic levels, to basically increase the impact of everything we do. And throughout, we want to ensure diversity, equity, and inclusion across all of our P-Core Trust Fund investments. So now our questions for you. Next slide. So are these the most important topics you would like the SNAC to address? Are there other things? Is anything missing? Are there refinements you want to make to the charge to the SNAC, and or recommended focus areas within our priorities? And what additional questions should the SNAC be addressing? And how can their input be the most useful to the NAC in providing guidance to AHRQ? So I'm happy to answer any questions, but at this point, I'm going to turn it over to our chair, Dr. Asaf Bitan, who's going to lead the discussion.
Well, thanks so much, Dr. Rhodes. And I think this was a wonderful overview of a very exciting initiative to continue to prioritize investments. If I may start the discussion, and really the discussion just to ground ourselves on, because we could dive into the weeds of each of the boxes, and that is actually what the snack will be doing. We want to, I think, try to aim, at least for the first part of our discussion, at a higher level about, as Dr. Rhodes was talking about, the strategic priorities. Are they right? Are there big areas that are missing? Is there an alignment or a cross-cutting set of through lines that we might be able to see? If I may, I'd like to start and sort of try to converge and hear what has been said earlier in this meeting and in previous meetings. If we look at the 5 categories that have been laid out in equity, care of people with chronic conditions, provider, patient, family experience, high quality, safe care, and primary care transformation, and then all the sub themes under them, I heard on this meeting and in previous discussions that the way that we think about 2 big topics almost set the stage for all those big priorities. So the way that we think about payment, the way that we think about quality sets the stage for everything else. Payment is what work and whose contributions are valued most within the healthcare system, literally dollars and cents. And we know how contributions and money flows across the health system sort of rank or sort of pay more for certain things than other things. I think that clearly cuts across all those 5 areas, and understanding payments impacts in those areas may be an area to consider. The other is quality, which is how we know what is happening and how do we make sense of performance. And we heard very clearly there's a continuing theme of too many measures that don't really give us a sense of actual performance, and clearly measuring performance with both validity, usability, and equity is a major theme. So how we understand fund flows and whose work is valued most, and then how we measure quality more simply and effectively, I wonder, and hearing the comments, might be cross-cutting themes that the snack could grapple with. Other thoughts? Okay, I see Yanling Yu.
Yes, thank you, and I appreciated the presentation. And we in the talk, it talked about the stakeholders and how get feedback. And I was just wondering a question. What is the plan? Any thoughts about how to engage the patient and families, the healthcare consumers into this, because they are the consumers of in the healthcare, so they are major, maybe the most important, the stakeholders for setting up, evaluate the assets, the quality, and the cost. And so I just wonder if you have any thoughts and to build this stakeholders into the whole equation of the work plan.
Dr. Rhodes, do you want to take on any of those questions, or mainly listen and compile them for the snack?
Yeah, I'm really want that right now. SNAC members are listening, and Dr. Dillon, who's a family physician and has done community engaged research, is listening and taking notes. And this is really about what the NAC wants. And so your comments are really appreciated. Thank you.
Got it.
All right. Maybe I just quickly, maybe it's some workshop and then reaching out the community, and then to collect, with the community, the patient and health consumer, what they think is most important in terms of access, quality, safety, and the cost that impact them the most. Yeah, thank you for the comment.
Thank you. I think Melinda has a quick comment in the chat, and then I'm gonna go to Joe Brown Spites. Melinda, if you're off, then I'll. Joe Brown Spites, please.
Okay, thank you. And thank you, Dr. Rhodes, for that beautiful presentation. You know, I just kind of wanted to echo those comments a little bit around community engagement. And I wonder, and I was just, you know, kind of looking at the strategic framework a bit. I wonder if there's a way to infuse sort of the CBPR approach in this when you're thinking about community engagement and how we get communities involved in sort of solving the problem around this, you know, patient-centered outcomes research. So that would be my comment. And I also wanted to comment that I like the focus specifically on calling health equity out. We might need to think about, like, how do we specifically address racism? Because that seems to be a word that we don't use a lot, but we really need to, like, explicitly address that as it relates to inequities, racially and ethnically. And then I also thought that I would just highlight that I like that language around, like, whole person care across the lifespan. I think that that really is the right space to be in. Thank you.
Thank you. I'm going to ask the, excuse me, the question that Melinda Bunton stated as she's just re-establishing a better internet connection. So Melinda Bunton said, could Karen comment on how this strategic framework will intersect with AHRQ's overall? Is it a subset? And that one I will ask to you, Dr. Rhodes, just a question of clarification.
Yes, so it's definitely a subset. And the fact that we engage staff from every office and center is reflected because they brought the priorities from their centers. So it's definitely integrated with our efforts, but then focused on our authorization, what we are allowed by Congress to do with these funds. But building an investing in AHRQ and building the infrastructure to do the work is part of that intersection. And we are investing in that way.
Wonderful. We're going to get to Kathy Ivory next, but before that, Caroline Carney just joined us, and I just wanted to have you introduce yourself to the rest of the group.
Hey, thank you, Asif. Hi, everyone. I'm Caroline Carney. I am the president of Magellan Behavioral Health and chief medical officer of Magellan Healthcare. I am an academic by my background and also have worked in policy in state Medicaid programs as the CMO for state Medicaid program. In my role today, I am largely strategic and looking forward at ways the insurance industry can improve the delivery, collaboration, and financing of care. So I was about to add a comment, Karen, to the chat about wondering if there was a way we could pull in the aspect of interacting with one's insurance coverage as how it relates to patient satisfaction overall with the healthcare system and how better to navigate those services as it relates to satisfaction. One side thing, I am an internist and a psychiatrist both, and I still maintain a little practice so that I can be close to what's happening clinically.
Thank you so much. And it sounds like, and Murray Jacobson said it earlier, as well as others, that, this critical issue of financing and understanding what the system pays for, values, and how people navigate those costs and those decisions may be important. Kathy Ivory.
Yes, thank you, Karen, for the great presentation. I'm just going to call out an issue that was mentioned previously this morning that the SNAC might wish to grapple with, and that is the whole strategy around informatics, health IT, AI, machine learning, all of those concepts, particularly since Suzanne Bakken, who's a key informatics leader, is part of the SNAC. So just a suggestion that could be a very important piece of work for the SNAC to consider.
Thank you. Yeah, this seems also another cross-cutting theme that keeps coming up. Other comments, suggestions, really around either the high level strategic areas or strategies within them, other topic areas that either might be missing or really knit across various thematic sub areas. This might be a shocking occurrence in my nearly 2.5 years on the NAC. I have never heard. There's churning of the wheels, not so much silence, thinking. Any other direction that you'd like to suggest to the SNAC, especially since so many members are listening in? Again, thinking maybe more of the right questions as opposed to the right answers, if there are any right answers. Melinda seconds the comments about the interactions of the priority areas with costs and insurance. We've also heard very clearly from a number of folks on the need to name the drivers of inequity, or as in systemic racism, as opposed to labeling it as equity without sort of the upstream constructs. David Schmitz, did I just see you jump off the?
Accidentally, no further comment.
Okay.
So one thing I would throw out as a question to the NAC is, how would you want the SNAC to take on the healthcare system to make, if we're using this money as authorized to make the health system better, at what level should we be functioning? And I'm really happy that to have Dr. Jacobson as a health economist, and I know my FAM's work to help in that regard. But we also have Medicaid directors, actually from your state, Dr. Schmidt. We've got people on MedPAC. We've got who will be weighing in on some of the finances. And how would you want them to take on communicating with communities, health systems, policymakers on the state level and at the federal level, and engaging them in ways that they have some skin in the game, and whatever we do could be sustained going forward?
I see Omar Latif and then David Schmitz.
I didn't have an answer to that question, Karen. I apologize. I had raised my hand earlier. I wanted to sort of echo what Dr. Baton started out with, which when you talk about the original quality measures, I think one of the areas that I'm concerned about moving forward is the impact of the measurements that we've agreed on conceptually. Well, we haven't really had universal agreement on, but various agencies within the government have defined some of the quality measures, CMS, HHS, many different measures. And SNAC, my understanding, was convened to sort of bring this together and help provide clarity to all of this measurement. Since SNAC was put together in the era of COVID. COVID impacts how we measure quality. And the delay or the lag time for when those measurements come out is 3 years. And so people will have forgotten about the impact of COVID when we take our 3-year average and add an 18-month lag for our data acquisition. So 4.5 years from now, we're going to see all this horrible data that comes out that's very regional and hot zones. And I think my comment is a hope that that's adjusted for prior to it coming out and not retrospectively is what's happened in the past. The body of research finds this out and then says to everybody, oh my gosh, this isn't really what we're trying to do or what we're trying to measure. So, my hope is that SNAC as a subcommittee of AHRQ focuses on clarification of what is good quality, focus on, one of their focuses on clarification of, are our metrics measuring what we say they're measuring? And are we taking into consideration the changing context of the environment? Because otherwise it really does feel like an I got you moment in healthcare at a time where healthcare is hurting in an unprecedented way, where labor is a crisis, where people are burned out. And if I go to the ICU where we ran, we had the capacity to run 10 ECMO patients and ran 16, and then I criticized their line infections when they weren't real line infections based on a historic definition that doesn't apply in our context, it could really derail a lot of the engagement that we're trying to rebuild at a time where we really need it. We have historic, unprecedentedly low engagement.
Thanks for those comments. David Schmitz.
Karen, thank you for the question, and I will make a humble attempt to begin to address that. I have some but limited experience in community engaged participatory research, and it certainly is a challenge to identify how to best communicate and really work with the community. But one thing that's come to mind for me, especially in rural states and rural areas in North Dakota, is certainly that there are good examples of shared governance within healthcare systems. I think of the makeup of the boards of FQHCs, for example, community health centers, and patient client participation in governance, shared governance. I think about community health needs assessments, and I think our state does a good job of not only conducting those, but coordinating and expressing those to be accessible. The responsibilities that hospitals have with regard to integrating with their communities to engage around health needs and the delivery of services. So those would just be two examples that I can think of, but focusing on shared governance might be a way to expedite community engagement and also to disseminate those findings into strategic planning. Many of those boards, whether it's a critical access hospital or FQHC, have providers as well who have a voice there and then can implement strategic plans along with patients, their clients, really their neighbors, as well as administration.
Thanks so much. Yanling Yu.
Yeah, thank you. And I just want to add just brief comments on the cost. OIG just came out a report, and it said that just in October 2018, there are a quarter of Medicare beneficiaries experienced, medical error adverse event, and they're about 40% of preventable. And when tied to the cost, it costs over several millions of $100 million just for those adverse events, whether they are preventable or not preventable. So I just wondering, maybe my suggestion is to this SNAC committee, maybe when you tie to the cost, also to look at the patient's experience, patient reporting about adverse events, also how that would tie to the overall cost, because they really have a great impact also, not just quality care safety, but also on the cost. So thanks.
Thank you. Other comments? Also, anything relating to Dr. Valdez's earlier discussion of AHRQ priorities and the subset of the PCOR Trust Fund priorities. Any discussion about the interplay with that? One nestles into the other, and there are clear legislative limitations to what the PCOR Trust Fund can build its investments into, and AHRQ's mandate is inclusive of, but wider than the PCOR Trust Fund. Anyone have comments on that interplay or suggestions for Dr. Rhodes, Dr. Valdez? Okay. Well, hearing none, Dr. Rhodes, I want to really thank you for you and your team's work in this area. I want to thank the SNAC that I can't see directly except for two members that are on the screen here, but thank you into the internet ethersphere for the work both past, present, and to come, and also just if there are any public comments, I think it's, just about noon, but, please do send them in if there are any public comments for later in the meeting. But hearing no sort of further comments on this part of the session, I think what we can do is take a break. I might suggest that we come back at AHRQ team, would it be okay if we came back at, let's say, 12:40 Eastern Standard Time? So that's about a 35-minute break. We're a little bit ahead of time. And we can get through the next parts of our meeting and perhaps even end a little early. But before I say that, is that okay, AHRQ team, that we do that?
Beaton, we need to start on time because the public was notified of when the discussion would start. So we'll have to start at 1.
Have to start at 1. Okay, so then I think we have
an extended have a long break.
Again, words I have rarely heard in these meetings. So wonderful about the opportunity for a long break. Thank you, Dr. Rose. Thank you, Dr. Valdez. Thank you to all the NAC members. We will reconvene at 1 p.m. Eastern time and really appreciate it. All right, well, we're going to restart our meeting. I want to welcome everyone back. Again, my name is Asaf Bitan, and this is the National Advisory Council meeting for AHRQ. Pleasure to see you all. If you can, I invite you to turn your cameras back on if that's convenient and you're okay with that. And welcome also to all of our public attendees and all of the attendees from across AHRQ and other institutions that play in to AHRQ and that intersect with AHRQ. I just wanted to welcome a couple of folks back. Just wanted to make sure that we welcome back my FOM. Thanks, I know a number of you had to come in and out of the meetings, and welcome back a number of others. Our next discussion is actually building off of a number of themes that we heard this morning, really about the ways in which many have said that in the United States, the design of the delivery system is actually, unfortunately, or fortunately, stems from the design of the payment system and not the other way around. Perhaps in our quality improvement and system improvement efforts, we'd do well to think about the delivery systems that we want to build and then design back the payment systems that actually support those delivery systems. Just some food for thought. But we're really lucky to have Joel Cohen, who's the director of the Center for Financing, Access and Cost Trends at AHRQ, talking to us, and he sent some pre-reading along about AHRQ's role in healthcare financing research, building off of Dr. Valdez's earlier comments about how AHRQ is really here to produce scientific evidence to make healthcare safer, better quality, a better access, more equitable, more affordable. This obviously gets not just into the affordability, but into all of the features of AHRQ's mission. And so before Dr. Cohen speaks, I want to just invite Dr. Valdez to give some framing remarks to the NAC, both around the discussion. So we'll go Dr. Cohen's presentation, Dr. Valdez's framing, and then the discussion, as I know, and I'm sure you'll have lots of good thoughts and questions. So Dr. Cohen, please.
Thank you, Dr. Bitan. I'm very happy to be here and talk to you about our work in health economics and healthcare financing research. What I want to do here is really just provide a bit of a background for what I hope will be a lively discussion later on about what people think, what the NAC thinks about where we should go with this work. But we've actually been involved in this kind of work for a very, very long time. And what I want to do is provide some background here and a little bit of history to give you an idea of where we've been, where we are now, and where we might be going with this. So to start with, I just wanted to outline, what our role is in health economics and healthcare financing research. And there are really 3 different activities that we engage in here. Number 1 is collect and disseminate data. And, let me talk, have been most involved over my career. And I've actually been with the agency for a very long time, even before it was an agency, with the Medical Expenditure Panel Survey. And to go back to the beginnings of the Medical Expenditure Panel Survey, it was actually our expenditure surveys within the agency were actually started in the late 1970s. And they were started by a group of economists led by Gail Walensky, who felt that there was not enough person-level information available about the healthcare system and about people who use the healthcare system in order to do the kind of economic modeling that you would need to do to really understand the system and understand where it would go and be able to predict what would happen if various things, if various policies were changed, et cetera. So they set out to design a survey that would actually collect the kind of information that you would need in order to make those kind of economic estimates. And that became the first survey, which was the National Medical Care Expenditure Survey, which was done in 1977. We repeated it again in 1987 and made some enhancements, et cetera. And then we're about to redo it 10 years later. So it was sort of a 10-year cycle that we were on with these expenditure surveys. What happened in the early 90s was the Clinton administration came in and was very, very interested in healthcare. That was the first big initiative that they had with the administration, and they created all these work groups, et cetera. They wanted to redesign the entire system. The work groups got together. They were trying to figure out how to estimate what the impact of different policy, and Bob was actually involved in a lot of this as well. He can talk about it, but we wanted to estimate what the impact of all these changes would be on the system. Well, unfortunately, the only nationally representative data that we had was from our 1977 survey, was already 6 years old and wasn't going to be repeated until 1997. So actually what happened was the administration speeded up the collection of that information. That survey was supposed to be done in 97. We moved it up to 1996. And instead of making it once a decade survey, we made it an annual survey. So it's a rotating design where we call rotating panel design, where we pull people into the survey and we follow them for 2 different years. 2 years. So we have 2 years of information on folks, and we're constantly in the field. So we're now going into we're in our 26th year of data collection with that survey. So these expenditure surveys, actually, we have quite a bit of data now. It's much easier to estimate what the impact of policy changes are going to be on the system. So that was a success, which really started with our agency. We talked a little bit about the Healthcare Cost and Utilization Project, HCUP, earlier. HCUP actually has quite a bit of clinical information, and it's often used for clinical research, but it's actually collected from billing data from the states, and it's all of the hospital bills from within the states. So there's quite a bit of information on costs and use as well. And we create some tools to work with that database, cost to charge ratios. So you can actually, even though they only have charges on it, you can get to the costs of what it costs to provide the hospital care as well. And we provide that information to individuals to use in their own research. The MEPS, of course, is disseminated publicly. You can download it from the website, lots of different files. And also for confidential data, we have a procedure for people to get in to use that as well. We also are collecting some other sources of data. I know Bob earlier talked about our plans to look at all payer claims databases, but we've also recently created a there was some talk earlier about social determinants of health and how important those are in terms of outcomes and also the costs and use of healthcare. We had wanted to create a file to use for our own research purposes. We actually got funding from PCOR Trust Fund to expand that, and we recently created a file, a social determinants of health file, which is easily linkable to other databases through geographic links, and that's again available on our website. We are continuing to update that. Our second activity is to conduct our own research. So, we do our own studies, reports, peer-reviewed journal publications in cost and financing access and quality of care. And we feel this is really critical. This is actually part of the data collection as well, because we have researchers who are ensuring that they design the surveys and design the data collection, design the analytic files, et cetera, and they use them themselves in their own research, which then feeds back into the design of the surveys and the data collection and the analytic files, and so that improves them over time, makes sure that they're analytically useful, up to date, et cetera, collecting the correct information. So that's really an important element of the work we do. And we also, third, provide a lot of technical assistance, both within the government and outside the government, on both substantive issues of healthcare policy and the use of our own data. We consult. Melinda actually can talk a little bit about the way we consult with CBO. We talk to them about their microsimulation models. They use our data in those models, and we talk to them about methods as well. Occasionally, we even exchange staff back and forth. One of our modeling division directors actually went to CBO to do their model, and we actually got one of their modeling people who wanted to do research who came to our group. So there's a cross-fertilization going on there as well. But we also work with ASPE, we work with OMB, we work with sometimes congressional offices. Typically, we work with the folks like the CBO and OMB and ASPE who are talking. We talk to the people who talk to the policymakers. So, we're giving them the information and the technical assistance, et cetera, and then the information goes to the policymakers eventually. Occasionally, we talk to the policymakers ourselves. Next slide, please. So just in terms of a little bit of the work we've done, I'll talk a little bit about it and then provide just a few examples of some historical and more current papers that we've published that are on topics of interest and high profile. But we've done groundbreaking work in the past on insurance coverage, expenditures, use of care, et cetera. The early survey, this 1977 survey, the lack of insurance was becoming an issue. People sort of thought they understood the insurance system. But as I said, in the 77 survey, we actually followed people for an entire year. So we knew what their insurance status was at all points during the year. So it actually allowed us to look at transitions of insurance throughout the year. And it was kind of a revelation to people actually that that people did not just have insurance, keep it all year, and that was it. There's actually quite a bit of transitioning going on between plans or in and out of insurance over time, particularly for public programs like Medicaid. There was a lot of in and out, and that was a revelation for folks, which really had implications for policy. Medical expenditures, we can look at population subgroups. We can look at disparities, types of service. We are basically the only game in town in terms of nationally representative information on expenditures by condition. Those data are used by other folks, used by BEA to create a satellite health accounts, et cetera. So, we do work on that as well. Use of care, again, looking at disparities, looking at usual sources of care, looking at the effects of insurance status or lack of insurance on who uses care and what kind of care they use, et cetera. Family characteristics, very important. It's not just the individual, it's the family as well. So we do work in all of those areas and have done. Next slide, please. So this is a paper by Alan Monheit and Mark Burke, who were with the center a long time ago in the 70s, actually. And when the original 77 survey came out, they wrote a paper about how the US spent its healthcare dollar. And they looked at, the concentration of expenditures by individuals. So basically what you do is you take the most expensive person, you put them at the top, and you array them in descending order of expenses down to the bottom. And then you can count down at proportions of the population. Of course, there's a sample in the survey, you have to weight it. So, but the weighted population down at different percentiles of the population to see what proportion of all medical expenditures they account for. And lo and behold, they discovered that it was actually a very small proportion of the population that accounted for a very large proportion of medical expenditures. And they actually went back to some previous previous surveys, and kind of pieced together that information. And if you look at the table, which is actually from a follow-up after the 96 survey was out, looking at the concentration, if you look at the top line there, you'll see the top 1%. And if you look over at 1977, you'll see 27%. What that means is that 1% of the population accounted for 27% of all medical expenditures in 1977. Lo and behold, that's actually quite consistent across time. And even after the 96 survey, if you go to the last column there, 96 payments, 27%, that's exactly the same as 77. Now we've continued to do this. And if you look at, we've written some papers about how it's changed. It's a little bit less concentrated now than it was then, but it's basically the same. You have 1% of the population that accounts for about 20 to 25% of all medical expenditures. If you go to the bottom, you'll see that 97, it says 50% in 97. What that means is that the bottom half of the population accounts for 3% of expenditures. Now, this is pretty well known now. When Alan and Mark wrote the first paper, it was not so well known. And it really focused attention on the fact that there are certain types of individuals who are really accounting for a very large proportion of medical expenditures. And if you're going to do anything about trying to control costs, you have to look at that population and see who they are and try to figure out how to work with them and try to reduce costs there. And it sort of promoted looking at preventive care. We discovered that these folks tend to be folks with multiple chronic conditions. So management of care was an important issue. So it really sent the medical care system in a different direction in terms of looking at how to control costs. Next slide, please. So another issue, of course, is eligibility for public programs. And again, in order to simulate eligibility for people or look at eligibility, you can't just have information about an individual person. You actually have to have information about their family, the family structure. You have to know their income. You have to know a lot of different characteristics. And in fact, in some cases, you even have to know whether they are offered insurance at their jobs. So when the CHIP program was initially instituted, it was for a particular period of time, it was reauthorized. Then after the ACA and the marketplaces came into being, there was a question as to whether you really needed CHIP anymore. So MACPAC, the Medicaid and CHIP Access and Payment Commission, which was the group that was created by Congress to advise them on what to do with CHIP, was wondering whether we needed to reauthorize it after the ACA. They actually came to us to ask us if we could look at what would happen if they didn't authorize it. And again, under the CHIP program, if a family has an offer of health insurance within the family, then they're not eligible for the CHIP program. So what you see here is, from the blue and red slices of those pies, more than half of the population, if you got rid of CHIP, would not be eligible for marketplace insurance. So you would end up with a lot of uninsured kids. That was one of the factors that that prompted MACPAC to recommend to Congress that they reauthorize the program, and it was reauthorized. This is an issue that's continuing. I mean, the program now is reauthorized, I believe, through 2023, but at that point, you know, they'll be asking again whether we need to reauthorize it, et cetera. Next slide, please. And this is a little bit more recent research. It's a paper from last year looking at coding intensity in the Medicare program. This actually uses Medicare claims data, not any of AHRQ's data, but it's by Paul Jacobs and Rick Kroenig. Paul is a researcher in our health economist in our center. Rick actually used to be the director of the agency a little while ago, but he's had an interest in these issues. And there's an interest, there's a question in the Medicaid program about what's called upcoding in the Medicare Advantage programs. And what this means is that Medicare Advantage plans are paid on a risk-adjusted basis. So they risk adjust the beneficiaries in the program and then pay based on what that risk profile looks like for that plan. Now, what this does is provide an incentive for Medicare Advantage plans to really code as much as they can and as strategically as they can. And that's not as important under the Medicare fee-for-service program. So what happens is there's one theory is that the Medicare Advantage plans are really coding to the point where they're getting paid more than they really should be, in excess of what they would be if people were in Medicare fee-for-service because of this upcoding issue. And Paul and Rick looked at, you know, where this excess would be going, and they hypothesized and provided evidence that actually the extra benefits really go back to the plans. There are two ways they can go. They can either go back to the plans, or they could go back to the beneficiaries in the form of lower premiums. They showed that really they tend to go back to the plan. So, you know, this has caused people to think that maybe we're overpaying, and there have been some reductions in the payments to the Medicare Advantage plans based on this idea. And what they did was create a new way of creating a risk profile based on prescription drug data, which isn't going to depend so much on how the plans code the conditions. So the CMS has actually looked at it. There's billions of dollars at stake. You can see there's a quote from Joe Newhouse, who's probably one of our most preeminent economists. He's a Harvard economist who actually Bob worked with, I believe, a while ago on the Rand health insurance experiment. But in any case, even Dr. Newhouse had a commentary that went along with this article saying that it was a first order policy issue. And there are really billions and billions of dollars at stake. So it's an issue for the federal budget as well. That's some of the current work that we're doing related to health economics. Next slide, please. So that's just a sort of flavoring of the kinds of things we do, the kind of information we have, the kind of studies that we do. We're, you know, working on these things all the time. We're there's a American Society of Health Economists annual meeting is this June. We have a number of different papers on a number of different topics on the agenda there. Our AHRQ staff have 14 different presentations there. And if you're interested, you should take a look at that, and you can get a better idea of the breadth of research that we do within the agency. And with that, I will turn it back over to Bob.
Thanks very much. And thanks for sharing the work that has been done in the past and the work that we're currently doing. For those who aren't from the field of health economics, I just want to let you know that health economics is really a very young field within the discipline of economics. It's only 80 years old, approximately. It is now, I think, evolved into what I think most of us who are in the field would consider a behavioral science, because we're really looking at the actual behavior of people within this economic and social structure. And it really has two roles, and it plays two important roles, I think. It plays the role of a key member of an interdisciplinary field that we call health services research, and that we consider broadly our group of researchers that we aim to get engaged through our grants and through our work, because it's usually a social and science and behavioral science members along with clinical expertise. And so many health services researchers and many health economists now become steeped in the area in which they study, whether it's mental health or it's organ transplants or what have you. So they can begin to understand the language on the medical side, and folks on the medical side can understand the language of the health financing and economics world. But health economics also plays this health policy analysis role that's really built on this knowledge that has been developed over the last 80 years, and also a set of tools that are really substitutes or complements, depending on the way you want to look at it, to what biomedical scientists have developed in their use of randomized clinical trials. What many economists do is use a technology or a methodology called instrumental variable estimation, or they use difference in difference methods. These methods and randomized clinical trials actually all come out of the same philosophical, scientific view of difference approaches, sort of characterized by Mills. And really, the purpose of the whole policy analysis work is to help and assist authorities, whether it's state, federal, or others, make resource allocation decisions, whether at the federal level, the state level, or even in the institutional level. Healthcare managers running facilities are often relying on these kinds of analyses to make that kind of critical resource allocation. Today, we face all kinds of financial sustainability issues within our own healthcare systems that are a result of a lot of other social forces that we often don't take into account. And I want to bring these to the table as we begin our discussion, because we're living in an aging population. We have large-scale migration occurring in our globe and in our country. We are still part of a huge urbanization movement in the 21st century. We see the effects of prosperity disease loads, these chronic diseases, even though today we're dealing with a contagious disease demand from the pandemic. We'll face future pandemic waves without question. And we're also dealing with technological innovations. So all these social forces are at play while we're still trying to deal with rising out-of-pocket spending. And in many countries that have universal coverage, and those of us trying to seek some kind of universal coverage in the United States, it's a major challenge, because how, in fact, do we organize and estimate the kinds of economic and financing issues that need to be dealt with? So I, as the director, have to make some resource allocation decisions myself. And I'm looking to you to help me prioritize and think about what needs to be done. The first thing that you heard from Dr. Cohen's remarks is that we've largely played second fiddle in this area for the last decade or so because of some political scares that the agency has gone through over the years. So intramurally and extramurally, we've been very engaged, but we've always been the bridesmaid rather than the bride in the last 10 years. So other agencies and other units have carried the policy analysis load. To what extent should I really be trying to have us assert our leadership in the department with regard to the kinds of economic analysis we do and the policy analysis we do? Should we seek our funding and do our funding more internally through a more robust intramural program? Or should we be looking to create a much more robust extramural program? Or is there some kind of balance in the middle that we need to figure out, and what should that balance be? And more importantly, what kinds of topics should this group be focused on? You heard Dr. Cohen talk about the vast number of topics that we cover. With such a small staff and such a small budget, it's from my management perspective, a call for us to be more focused on a few topics where we can have some real push rather than trying to cover the waterfront. On the other hand, there are critical issues that perhaps we're not even touching. And so what should we be looking at today? And more importantly, what should we be preparing ourselves to look at for tomorrow? We have a very senior staff. So we need to think about transitions to new scholars and new techniques and new technologies. So we need to think about that kind of transition that undoubtedly is going to be taking place in our division as people begin to retire. I need your critical strategic thinking about where do I put resources, where should we move, and how can we position ourselves best within AHRQ and its potential future.
Thank you, Dr. Valdez. And we have a wonderful array of folks who raise their hands. Murray Jacobson, please.
Thank you. Yeah, first, just to say, as both a user and consumer of the resources from AHRQ, they're invaluable and amazing, and I hope they continue. And so my comments are really about, particularly with respect to the MEPS, about kind of how we can continue to make it even better. And so one of the areas that MEPS doesn't capture is people in institutional settings. And as we have an aging population, that becomes more and more important. And so as you're thinking about how to kind of innovate on the MEPS space, just thinking about institutional care is one thing I wanted to kind of put out there. The other thing, and this may be a little bit selfish based on the type of work I study, but infused drugs, which is not something we think about commonly because most people aren't using them, but are actually very costly, are another thing that are not captured in a very precise way in MEPS. So I would just throw that out as another thing to think about. But I love the work all on concentration of healthcare spending. And I would also say the MA work is increasingly important as this population grows. So thank you.
Thank you. Yanling Yu.
Yeah, thanks. I have one question and one comment. And first of all, my question is about AHRQ data. I know there's lots of information in there for policymakers, managers, and healthcare researchers, et cetera. And I was just wondering how much there is a public interface for those data be available, or more geared towards helping consumers to find the most critical information that help them navigating through inpatient and ambulatory care. What I mean is, in terms of the safety and quality outcomes and access of cost. I know I talked to a lot of patients, and it seems not many people really know the AHRQ data available, what's in there, and how can they use it. So I thought, the question is, do we have a public interface there to educate the public how to use it, or data is there?
Dr. Cohen, could you respond to that?
Yes. We do have a public interface. We have a website, which is AHRQ US, which doesn't stand for United States. It's user support. We have increasingly tried to make the data more accessible to folks. So we've got, data visualizations. We've done work on redesigning our summary data tables, et cetera. I will agree with you that this is an issue. And a lot of our web, sort of access, particularly under both MEPS and HCUP, is old. It's a sort of a legacy system. It really needs to be redesigned, and I agree with you there. It's coming up with the resources in order to do that redesign. But we are increasingly trying to move into an area with, to make things more accessible. And, part of it is translating HCUP is a huge, you're talking about millions and millions of records. And so, you have to figure out a way to boil that down into something that a consumer can actually understand. Right. But, we do, as I said, we have some of these visualizations, et cetera. I'd be interested in finding out how consumers, how much they really understand or are able to find those things, and improving our ability to get that information out to folks who are interested in it. It's certainly an area we're pushing on. It's a little bit difficult. You have to find the resources, and then you have to figure out a way to take these masses of data and put it into something that somebody can understand. But, I absolutely agree with you. That's a really, really, really important area. And I think, the state of consumer information about the healthcare system out there is really kind of abysmal. And I think anything we can do to improve that is really worthwhile.
Yeah, I understand it's a tremendous challenge to figure out what exactly practical and people can understand for common people, So I would be happy to assist the efforts and then to reach out on my network and to find out what people are interested in and how much they will understand, and maybe just look at some data like that. And yeah, I appreciated the efforts and, great job. Another comments that I would like to make, just like each company has all kind of a data, all payer, data from the state, and whether they are transparent all to patients and consumers. And, we all know, we are healthcare consumers and patients. And I just hope that the agency will keep in mind that bring, healthcare consumers, patients into the equations to solve the cost problem, because they are the consumers, we call it. So, smart healthcare consumers and patients are those who are well informed about the cost issues and how to best spend their bucks to get the best care that is consistent with their, perspective of their life, in the goal in life. And what I mean, the best care, I mean the safer and better quality care. So I hope agency keep in mind that always bring patient and family into the equation when you try to solve the problem. So thank you.
Thank you.
My phone.
Hi, Joel, thank you for that summary. And I honestly can't believe how much you produce with your resources. So in that spirit, let me pile on another request for you. I actually think that there's a massive national gap that I can't think of another agency besides AHRQ being able to fill. And I understand that it would take resources. I don't even have all the answers for you, but here's the question. What has the impact of private equity been in healthcare delivery and outcomes? I think this is a very modern question. There's always been capital investment in healthcare. I think it has just taken on a magnitude and a breadth that that was unprecedented, is unprecedented. And regardless of what happens going forward, I think we have a lot that we need to learn about that and how it has played out over the last decade or so. I don't know what the right data sources or data partners might be. Is it some combination of the IRS, the SEC, the Federal Trade Commission, other regulatory data sets? But I don't think anyone has really pieced that together except in very small niche parts of the market where there's been some research done. And I think that the questions are deeply important for the country to understand. Not just what have the quality and cost impacts been of different types of equity driving healthcare business decision making, but also where is that money flowing? I mean, I just feel like I'm missing the basic statistics. Like, is it rational money? Is the money chasing actual margin, right? Or is it chasing volume of need? Is it being irrational? I get the sense, qualitative sense, that there's a ton of stupid money right now in healthcare. And wouldn't it be wouldn't it be great if we could re-steer that, right, in better avenues or more constructive investments? I don't think that investors are working with the best information, and I'm pretty sure that policy leaders aren't working with the best information. I don't think that CMS, for example, has many people within its walls. Having lived there, I don't think that many people within its walls really understand how markets work in a way that AHRQ could help them understand. And also bringing in all of these other federal and regional regulatory partners to leverage the equity interest that is out there. Sorry, I'm another impossible task, Joel.
It sounds like maybe you'll take it on or find friends to take it on. Melinda Bunton.
Hi, thanks. So my first comment or suggestion really follows on the very last thing that my family was saying there about what goes on within the halls of CMS, and also Bob's comment that AHRQ is often the bridesmaid in these policy discussions. And I would love to see AHRQ and the very, very talented health economists and analysts you have involved more as, we'll call it the partner at the altar rather than the bridesmaid. And I think there is a real opportunity for that because of their analytic expertise, their deep understanding of data, and their ability to comment on what's going on at CMS in a way that is both constructive, but also arm's length. So there are millions and millions of dollars spent annually on doing evaluations of things that CMS is doing that AHRQ could participate in and possibly do better, faster, and at greater benefit to the department as a whole. And so I would suggest that that's an avenue for opening a discussion with a sister agency and thinking about how this might happen. And I would offer this both on the health economics side, and as relates to the value-driven care agenda, and also to the quality agenda, where I think there's so many synergies that are not yet explored. And I think that this could be done in a way that is very pragmatic and sort of at the civil service level as opposed to political. The second thing I wanted to note relates to the comment about access to data. So if you go to data.gov, which is the source of data, federal open data, the only topic area related to health is older adults health. But if you click on that and you go down a few levels, you find both HCUP and MEPS. HCUP, it says, is restricted and doesn't really tell you how to get access to it. And MEPS, as soon as you click on it, it asks you for a user login, which you would have no idea how to get. So I would say, a first step is just to make sure that your data are accurately represented and accessible, at least instructions for accessing it through where most people go for government data, which is data.gov.
I'll have to
Thank you very much for bringing that to our attention.
Yes. It's interesting that it asks for it must be going to the sample person site, the people who are actually sampled into the survey for there, because otherwise you wouldn't need because the MEPS website is obviously the link is messed up. I'll have to look at that.
Caroline Carney.
Thank you. I am piling on also to the comments about private equity. Based on what I have seen in the last few years in the behavioral health space, if that kind of money had gone into the behavioral health system in the first place, we might have a different situation right now. And there is a great deal of money being poured into the mild moderate space at the expense of where likely most of the spend and the morbidity are coming from today. That was my editorial comment. Bob, in response to your comments and also in response to the data shared by Joel, I cannot help but think of the interface between mental health conditions and the primary care sector. And that is where most present first, and I think is worthy of a great deal of study to determine if we could move upstream in diagnosing and treating behavioral health conditions in the primary care sector, would we ultimately reduce downstream cost and downstream morbidity? There are a few papers that suggest that if we treat behavioral health, we'll see an overall decline in the cost of care, but those have come out of industry, out of Milliman, and most recently out of Cigna. And so to have a solid health economic study of this, I think would be a great addition to the market. We have seen directionality in that, of course, in the collaborative care model, but I think even outside the collaborative care model, looking at that cost of care, the use of medications in the primary care setting appropriately or inappropriately to treat behavioral health conditions, I think is a real key area given what we're seeing for the need of behavioral health treatment in the country, and that we're still heading toward the nadir of the available providers. The second area, looking into the future, it's taking what's happening today and looking into the future. I sit on another committee through AHIP, and we struggle mightily with the use of telehealth and wanting to promote access to care, but not really knowing the outcomes of the quality of care necessarily with teleservices as they extend into pediatric care, general family medicine care, and especially behavioral health care. So I think the kind of longitudinal studies we can see in delivery of preventive care services, acute diagnostic services, overuse of therapies like antibiotics in that setting, and so on, I think would be something worthy of future look, because I can't see us ever moving fully away from telehealth. And then the final comment I have, looking even further, is to consider the outcomes of alternative treatments and what they are going to produce in terms of cost of utilization and outcomes of care, particularly with therapies like virtual reality therapy or psychedelic therapy, or things that are out there in FDA approval processes and soon to be available to a much wider scope of the population. Thank you.
Thank you. And oh, please.
No, I was to say thank you for this list of potential areas that we should be spending some time on.
Just a wondering, these are critical areas ranging from, the PE entry issues to, modeling out VR and AR. Assuming there won't be VR maps coming out next year, unless you all let us know, one of the things that comes to mind is that AHRQ certainly has power of purchase through its budget and through extramural and intramural funds, but it also has a convening power. And in these areas where we're not even sure where the data is, there's probably not nationally representative data, but there's nationally representative trends, whether they stem from all those that were just discussed, from medication use to AR to private equity, et cetera. AHRQ might spend some funds on convening groups of thoughtful academics, practitioners, administrators, and policymakers to figure out a path to how one would even start investigating these issues, not of the future, but of the now, but for which the data of the past don't answer the questions of the present. And so, you never want to just convene conferences to have a white paper that takes up electronic space somewhere and doesn't do anything. But I think that AHRQ can do more than that and convene, sets of questions and early answers that might give you some directions on where you want to invest your funds in these new modalities. David Schmitz.
Thank you for the opportunity to add another group of projects potentially to the list. And I'm fascinated with regard to the ability to take the use of care data and see how that might be representative to access to care, which will be a theme since I'm very concerned with rural access and quality. For example, one could take patient transfer diagnosis codes data, whether that be from an emergency room setting or from an inpatient setting, where patients are transferred to a more urban resource-rich setting, and determine if that is something based on diagnosis codes that could have been cared for should we have the proper workforce or training of workforce. I'm a medical educator myself. How can we keep patients getting quality of care as close to home as possible? And the reason that I would advocate for that is I think it can lower costs, duplication of services. If you would imagine an older adult who has multiple chronic conditions and perhaps is then discharged to a transitional care facility or a longer term care facility, doing that from a distant center just is very disruptive with regard to other social support and meaningful patient outcomes for that person. And so I just thought it's not my new idea. It's something that's been discussed in smaller circles around rural research, but being able to understand how to reinforce local capacity and avoid not only the fraught dangers of transfer across distances, but to really help to enrich the infrastructure that supports patient care services as close to home as possible. And I think this is a time to do this. And one of the reasons I believe that is because telemedicine and telehealth will certainly have positive impacts for healthcare access, but it is also innately going to be, I think, a disruptive innovation economically with regard to the provision of some primary care services and the underpinning of the economic basis for hands-on workforce in rural places. So that's just a brief summary on why I think this should be an area of emphasis with regard to avoiding unnecessary patient transfers going forward.
Thank you. Patrick Romano.
Good afternoon. I've been uncharacteristically quiet so far today, but I actually have a lot to say on this particular topic. And one, I'll pick up on the theme of access. I think that there's, of course, tremendous interest in the current administration with improving access to care, with ensuring that the Affordable Care Act is fully implemented and that it meets its promise of improving access to care for all Americans. In addition, we are at a critical time when many of the COVID era exceptions and emergency authorizations are being phased out. And so this potentially will have a deleterious impact on the access to health services for some Americans. So I think going forward, I think an important role for AHRQ will be to understand what do we learn from the COVID era in terms of the policy changes that were implemented on an emergency basis. What do we try to keep and build on going forward? And how do we ensure that whatever coverage gains we've achieved during the pandemic, as painful as they are, that we retain those benefits going forward, and that we don't go backwards in terms of particularly some of the issues around Medicaid eligibility across all the states in the country. So I think there's some very important access issues. Telehealth has been an important part of that. So I think that AHRQ has a role potentially in partnership with other federal agencies to understand what is the role of telehealth in improving access and quality in an efficiently functioning healthcare system. Again, how do we ensure that telehealth is to some extent substituting and not just adding another layer of spending onto the healthcare system? So we, of course, immediately moved into doing almost everything by telehealth. And now we're back in person for most of our care. And yet we need to understand better how to integrate telehealth with in-person care to optimize the efficiency of the healthcare system. So first theme I'm interested in is about access. Again, some of the same issues that David raised. Second theme about price and competition. You've cited the work of Herb Wong, which has been very important in this field. But I have no problems with price regulation myself, but we have come to depend in this country largely on competition to constrain prices in the commercial sector. Inflation has hit the economy as a whole. It's hitting healthcare very hard. We are going to see an unprecedented degree, maybe not unprecedented, but unprecedented in the 21st century, degree of inflation in healthcare prices, unless we pay careful attention to what's going on. And we see, of course, Mai has mentioned the role of private equity, looking for profit opportunities in the system. We also see the merger mania is continuing, right? Just this week, two major health systems proposing a merger. There are other federal agencies, FTC and DOJ, of course, that are the lead agencies on enforcing antitrust law. But AHRQ is a critically important partner with these agencies because, frankly, these agencies don't have the detailed understanding of health data to really figure out when to intervene, when not to intervene, and how to enforce antitrust law to promote the benefits of competition. So it's really important, the work that AHRQ has done in this space. I know personally from work I've done with FTC over the years, that FTC has depended very heavily on the AHRQ quality indicators and some of the work that Herb and Ryan Mutter and others have done to make policy decisions related to antitrust enforcement. So this is a great example, as Melinda mentioned, where AHRQ can be, not necessarily a bridesmaid, but right there at the altar, working with other federal agencies, particularly FTC and DOJ, to figure out how do we understand how competition is evolving. There's a tremendous amount of interest in what's going on in long-term care, in what's going on with hospitals purchasing physician organizations, and what are the impact of all of those relationships for pricing. So I really hope that AHRQ can expand and develop a robust portfolio, both intramural and extramural work in this domain of price and competition.
Thank you. Kathy Ivory.
Yeah, thank you. So a couple of things. I made a comment earlier about the need to get more serious about looking at attribution of individual members of the care team. I think examining the financial and economic implications of the contributions of varied members of the healthcare team is certainly worth exploring as we think about financing healthcare for the future. So that's one point. The second is one I haven't heard talked about yet before, and as we think about partnering with other federal agencies, I think about the Department of Labor. I think we had particularly in healthcare, we had a worker shortage before the pandemic, but coming out of the pandemic, we have a worker shortage across the board. And when we first started bundling healthcare coverage with employers, it was to attract workers. And what are the implications now about unbundling healthcare coverage from the employer? And what would be the financial and economic impact of doing so related to the ability to affect wages? So haven't heard that mentioned yet, but think it's worth AHRQ's substantial experience in healthcare policy related to finance.
Thank you. And that reminds me to draw up Susan Edgman-Levitan's comment from earlier about specific to primary care and the recent National Academies report, which endorsed this sort of tiered model of team engagement, both inside the clinic walls and outside the clinic walls, inclusive of community services and real connections between primary care and community services. There's a real need, and I think I heard you speak to that just now, of really understanding not only who's on the team, how do they integrate, how are they not just supporting doctors and not just inclusive of doctors, but also how do you pay people outside of health system walls? And what are ways of financing health systems to be much more inclusive of the engagement mechanisms that, quite frankly, they need to meet their stated explicit mandates toward equity and community responsiveness while we're still in COVID and beyond. Omar Latif.
Yeah, thanks, Doctor. But yeah, Joel, in one of your sort of slides you referenced sort of the MA plans. And one of the assumptions and one of the statements that's being made across the country is perhaps these are being overfunded as a function of coding. And if coding is an opportunity, then several people in the planet have drawn the assumption that there's an overfunding in MA programs. I think that would be a statement so powerful that my colleagues in safety net hospitals would probably have 3, 4, or 5 vessel, explosions on in their hearts. The idea that these are overfunded programs. The overfunded program, and this is where AHRQ is incredibly valuable. There's an incredible knowledge and data and the ability to translate data into a usable format for someone to draw the appropriate conclusion. So a properly funded MA program, or an MA program that turned out to be very lucrative, tends to be in a different neighborhood than an MA program that's not, or they may have a better function of coding. Where coding is a problem, it has to be called out. But if coding is the measure by which we paint the picture of a patient, and that measure is used for not only payment, but high quality, low quality care, good versus bad, infection, no infection, we have to ensure that there's accuracy of coding for the moral right purposes. And I think AHRQ has the ability and the talent to do that in conjunction with other agencies that are just drawing simplistic conclusions without understanding that each MA program is different, each community is different, and each program treats a different subpopulation. So the MA program in inner city Chicago that we run is not profitable. I assure you, we invest a lot in as much coding as we possibly can. And there's not only is there no hanky panky, we do it running it at a loss, as does Cook County Health and as the other sort of county systems or mission-driven systems in the country. So I think it's an opportunity for AHRQ to take their knowledge and translate that knowledge into policymakers so that the policies can better represent the communities that need more access to care.
Thanks so much. Just any response to any of those comments, Joel Cohen, Dr. Valdez?
Well, just to say, I think that's an important issue in healthcare, because often, people look at things on average, and there's a distribution, and you really have to take into account the distribution. And you're absolutely right. What's true for a plan in one particular area may not be true for a plan in another area. And I think it goes across not just that, but all sorts of, you can even look at that in terms of like some prescription drugs, et cetera. People say, well, they're not more, this drug's not more effective than that one, but it depends. It may be for certain people, but not other people. And, so you have to be very careful, I think, when you're looking at averages, and because you can reward the people you don't want to reward and harm the people you don't want to harm if you don't do that correctly. So I agree with you completely. You have to be very careful with that. And that was one reason that Paul and Rick were thinking that looking at the prescription drugs that people got might be a better way of determining what their risk was than just looking at what diagnoses are coded as according to the plan. So that was the whole point there. And I think it would discriminate across the different kinds of plans, because it would be less dependent on how good the plan is at upcoding.
So
CMS was actually very interested in this method, and so they are looking at it themselves. So they're using it in their internal discussions as well. So hopefully that will actually feed into what happens with that process. But I agree with you. people talk about averages all the time, and that you have to take into account the distribution. It's like the concentration of expenditures. On average, it's not, it's at a certain point, but there's a few folks who are like hugely expensive, and if you're gonna do something to try to if the problem is that they're just sick and need a lot of care, it doesn't. What are you going to do to try to reduce that and not take away needed care? So you just have to be careful about the way that you apply these things across a full distribution of the population.
As I always like to say, all healthcare is local, and sort of what resources are available in local communities and how they get put together and how they get used have to be part of the overall analysis. And I think Joel's right. We generally tend to look at averages or medians in trying to make larger decisions. Even the analysis that was illustrated was done at the state level, and that in a place like California, that's not very meaningful. The other big state was Texas. That's not very meaningful either. Very different kinds of medical markets, very different kinds of resources, very different even medical variations that are due to philosophical differences in the way medicine is practiced in those communities. And so it's a complex thing, and we have to get better at trying to understand how we include those factors into the way we analyze and make recommendations from the analysis that we do.
In our last few minutes, I just want to remind the committee we were earlier, Dr. Valdez charged us with getting our read on whether AHRQ should expand its intramural or extramural program in this area. And I listed a few other topics that came up, but Yanling Yu, and then followed by my phone.
Thank you for giving me a second opportunity to speak. I have a question regarding the cost for the COVID during the pandemic. I mean, we just passed a 1 million marker for people who died of COVID infection, and every person who died, then there are about 10, maybe more people are infected, family members, communities, and every loss of a human life, human cost can be transferred to economic cost. So I just wondering if AHRQ has any plan in the future using HCOP type of a platform to analyze or research in collaboration with other agencies like a CDC, CMS, or state agencies to figure out what is the true cost for the US and dollar amount to dealing with the COVID. This type of emergency, public health emergency gonna come up again, probably because of climate change and all other issues. So how are we gonna prepare in this type of failure mode, and then what the cost associated with it? I just wonder if the agency has any plans on that.
Well, we do coordinate with CDC and with ASPR, which is the Assistant Secretary for Preparedness and Response. And we have used HCUP to try to prepare for different kinds of emergencies. And certainly early on in the COVID pandemic, there were a lot of questions about what the hospital capacity was across the country. How many ventilators there were out there, how many ICU beds there were, and there wasn't particularly good data. Now, there is a lag in HCUP data, but we did use it early on to try to give folks an idea of what's out there and what the capacity is. As time went on, CDC developed more data systems to try to get more current data, sort of up to date data on what's out there. So that's certainly available. In terms of cost, I think we've looked less at the cost of things and more at what we needed and, you know, who was being affected by the pandemic and, you know, where we thought we needed to put resources in order to respond to it. But certainly, as I said, we have cost to charge ratios that you can apply to the HCUP data to get an indication of what costs are. But I don't know that anybody's actually used those. CDC does that, you know, they sort of, you know, burden of illness kinds of things. We have tended to get less, you know, to be less involved in that sort of thing, because there's certain assumptions and, you know, people have different methods of doing it. And it's, you know, I think more of a CDC kind of activity than an AHRQ activity, but certainly, you know, we help in terms of, you know, trying to prepare. We have data that we could certainly offer to them. And we have lots of discussions with folks in the CDC about, you know, different kinds of analyses and what they're trying to do, et cetera. So we're talking to them all the time. That particular issue, I don't think has come up, but that's not to say it won't in the future.
Yeah, okay, thank you.
Ifan?
Thanks again for a second shot. There is another ginormous industry gap that I think either AHRQ or CMS could fill, but you're not as constrained directly by the politics as CMS is, because I have these conversations with them all the time. We need to modernize risk adjustment in a big way. The traditional tools that are regression-based, that are static, that have never had R-squareds much better than 0.2, they are not going to be sufficient to capture where they were never sufficient. I mean, they were the best that we could do, but we have other tools and options now that could be brought to bear to vastly improve risk adjustment. So out there in the private sector, again, I go back to the socioeconomic data, which is not geographic only. It is person level, accessible, purchasable, and it is now a commodity in the marketplace where you can get individual level data for adults and household level data for children on a vast array, hundreds of socioeconomic factors that then can be used in machine learning, much less static models to predict service use, outcomes, and spend. This is being done in a very utilitarian way in the private sector, right? People looking at one specific outcome or a really high cost subpopulation. I have not seen it used for purposes of developing risk adjustment tools, and I cannot for the life of me figure out why. That we are spending $2 trillion just in the public sector on healthcare services with tools with R-squareds of 0.2 or less. And so I want to push AHRQ to think about that because, you know, CMS, there's a different political threshold to deploy it in a program before it has been tested elsewhere. That is AHRQ's role. And you can also lead the entire industry in thinking about, well, you know, the fact that a regression-based model requires a human being, a smart human being, but a human being nevertheless, to proactively identify likely contributing factors and potentially their relative influence in order to build the model, right? In order to figure out how to construct the right-hand side of the equation. But a machine sees patterns much more efficiently than humans do. And this is not to say that artificial intelligence is the end all, but I don't think we've tried to deploy it here yet in an area where we know that we have not had adequate tools. I'm begging you.
If there are baseball fans here, I understood your comment, Mai, to really be one around. It's clear AHRQ has always been good at calling balls and strikes, but it also can build out new methods of sabermetrics and all of the quantitative tools that 20 years ago sort of revolutionized baseball analytics and really helped people make better predictions and better analyses of the entire game. And that might be a good role for a small but mighty federal research agency like AHRQ.
And one that is a bit removed from the politics of the day-to-day grind, and that could bring real credibility to new methodologic approaches.
Great. Caroline, I know you've been patient. Caroline Carney.
Thank you. Second time today building on Maya's comment, I would have to say in the insurance industry, the kind of work that Maya is describing is being done every day. I have a team daily looking at suicide risk models to target individuals who need outreach sooner as opposed to later to get them services for that very end. And so it is pulling in social determinants data, it is pulling in EMR data, it is pulling in algorithms to look at individuals who are likely to have levels of utilization because they didn't get the right utilization up front for a variety of factors. And so while machine learning models are not perfect, they give us much, much better directionality than the current risk adjustment models as described. So there are many experts that are available, perhaps Joel, for you to partner with. And I think it would be really fun to look at bringing some of your data into those models. I think that would be incredible to see what we could find in some of the existing data that AHRQ has. I did want to make another comment about the future of where we may need to head. And and build on also something Omar said with regard to current risk adjustment and are people getting rich off of it versus others who are not. And I would recommend looking at circling back to the beginning of this discussion, private equity organizations who are stating that they save so much money based on their interventions when really when you dig behind it, the money is coming all from upcoding and doing that kind of work. So there's a definite signal of where these models are not being used correctly. And again, I think often at the expense of what's really good standard healthcare can bring.
Thanks so much for those comments. Before we go to Omar Latif, Murray Jacobson, did you have, I heard perhaps maybe the promise of AI is oversold. I know that there's a strong camp that believes in that too. So this is a great discussion. I just open it up and then we'll go to Omar Latif.
Yeah, I think that the returns are really to actually just using the data, and that when we look at R² and many of the best models and the best people doing these models, the returns we get are really, really small, which isn't to say we shouldn't invest in that and do that. But I think we risk ignoring the fact that just getting the data, collecting the data, processing the data is huge. And that kind of the revolution right now, it's not there yet. So I don't think we should ignore the importance of actually just collecting the data and processing it in the amazing ways that AHRQ already does. So that was my comment. Thank you.
Thank you. Omar Latif.
So, yeah, no, I got so excited in the conversation. I didn't know what to do with myself. And then, so I raised my hand. So I apologize for that. But since I'm talking, what I would say was that the benefit of AHRQ being unbiased and sitting on the outside looking in is to help provide and proffer clean, interpretable ways to use all the data that comes out, whether or not it's from AI, whether or not it's from an Excel spreadsheet, right now, whether or not, wherever it comes from. I think we have a responsibility and an opportunity to help use that data to clarify what happens. Because when you look at the success story of private equity in healthcare, it's not necessarily related to a success story of improving health of communities. I don't know that data exists right now that shows private equity made $16 billion in a community and the death gap decreased by 5 years. In fact, I would probably argue that private equity picked out the profitable parts of the opportunity and left other well-meaning medical facilities to take care of the other patients. And that's a theory. And I think we need to use the data that we can compile here in an unbiased way to turn the lights on to say, what is the downstream impact of well-meaning programs because it's very possible that it will drive racial inequity. It's very possible many of these programs will drive that. And so we have that opportunity to clean that data.
Thank you. I'm going to ask our AHRQ colleagues to let us know if there are any public comments that we should be building time in to share. And then I put one more prompt in the chat for anyone's opinion on Dr. Valdez's request for opinions on an extramural research program. But Mamatha, any public comments for us to leave time and space for?
Thank you, Asaf. First, let me just say I'm Mamatha Panchali. I apologize for not introducing myself earlier. I'm sitting in for Jamie Zimmerman, who is your official for the NAC, and there are no public comments at this time. So I think if you wanted to go right into Chair's wrap up, I think that would be great.
Thank you so much, and thank you for being the designated federal official for this meeting. Melinda Bunton, I think I see a hand up there.
Well, I was just going to respond to your question about extramural support. I wanted to say both that I think extramural support has really been an excellent way to extend AHRQ's reach. You're always, as a Fed, constrained by hiring limits and things like that. So it's such an important part of what you do. But that also that the Jacobson Chronic work was a way to have an intramural researcher paired with an extramural researcher in a way that was clearly extremely important for policy. And that's also a nice model to follow.
Thank you for that feedback. Any other comments specifically to the questions of murality, extra or intra? While you're reflecting on that, we are in the
Can I just,
oh yes, please.
Sorry,
please.
on that question, can I just ask whether Bob or Joel have a point of view about where, if AHRQ were to invest in that extramural program, how that would interact or not replicate the various relevant NIH study sections? Like,
Well,
do you and
ahead.
NIH get together and say, we will take this and you will take that?
Well, first of all, I think you need to recognize, and many people in the research community don't recognize, is that NIH is a biomedical research institution. And the whole area of economics has actually not been an area that they have invested in, nor have they wanted to invest in historically. More recently, there have been some initial areas. As any large institution, there are programs or institutes that have sort of weighed in and begun to look at issues around costs and financing, but it's not a central role of that agency. So I think it's extremely important to recognize that this is the only agency with the real authorities to look at those sets of issues that are outside of the regulatory or payment arrangements that have been talked about today with CMS and with others. So to a large extent, it's about how do we in fact raise the resources if in fact this is where we want to go. This becomes my job of trying to figure out how we find the resources to actually do this kind of program and to pursue this kind of research, which has, as I said earlier, largely been put on the backside of what AHRQ does and in supporting work for other agencies that don't have the capacity and don't have the authorities to do that.
Great. Patrick Romano.
Yeah, I just wanted to, again, strongly vote for a robust extramural research program in this area. I think, as you've alluded to, Bob, health economists, and I don't just mean health economists, but I really mean those of us who work with health economists, health economic groups, often have a lot of difficulty getting funding for questions that cut across body systems and questions that cut across diseases. NIH still has a very strong focus on diseases and body systems, which is not helpful in an integrated healthcare system. And so if we want to address the kinds of questions we've been talking about, questions about pricing and competition, and how do we understand the role of competition in constraining prices in healthcare? How do we understand the role of private equity? This is a ripe area for extramural research, and it's a ripe area where AHRQ could make some tailored funding announcements to request work in particular topics that would really advance the field in terms of building better measures, better tools, and a better understanding of some of these critical issues that will be affecting healthcare spending over the next decade.
We are the home for health services research, and that includes, as I said earlier, an interdisciplinary team of scholars who work to answer these kinds of questions that include health economists, but also include sociologists, political scientists, epidemiologists, and clinicians, quite honestly. And so we have not, as a society, invested in that kind of interdisciplinary research and interdisciplinary research questions, which is why I've been honored to be asked to lead this agency, because this is the home to my own professional area of expertise, which is health services research, and where I've surreptitiously had to, over the course of my 30, 40-year career, relied on NIH dollars, but all the health services research work was always extra, and the biomedically oriented epidemiological work is what sustained me within the university setting. And I'm sure many of you have had that similar experience. But it's, I think the time is ripe, given the pandemic, for us to really begin to try to flex our muscles to really raise the importance of health services research and trying to answer the kinds of questions that need to be answered to really transform and fundamentally transform the care that's provided in the United States that results in really higher quality care and more efficient care and certainly safer care.
Thanks so much. Any last comments on this topic area before we transition to the wrap-up session? Well, I'm going to take a shot at Yanling Yu, please.
I just want to echo Bob's comments about, integrate healthcare services and health services and healthcare together to provide the care. I think that's definitely the directions I would really highly like to see happen. And just in terms of a training, we have team staff training just for the healthcare team. I would highly encourage the agency have all the modules for team care on the AHRQ's website. Somehow develop some module to include those health services, how they integrate into this whole team care concept, and how to a practical model people can use to follow. I think that would be great.
Thank you.
Thanks so much. Well, in this last session, I will take a shot at very briefly introducing the conclusion, reflecting on what I heard, and really open the space. Would love to hear your thoughts as NAC members about reflections on the topics presented today from Dr. Valdez's vision for AHRQ in these future years, in this sort of peri-COVID terrain, in this more inclusive and integrated view of health systems. We talked about the PCORI Trust Fund priorities and the SNAC advice to the SNAC members. And then we had a robust discussion just now on healthcare financing and cost studies and its role and AHRQ's role in promulgation of new methods, as well as continued very valuable inherited data sets and products. So I really hope that you can all, or whomever would like to offer their thoughts. I'll give you brief thoughts on three things that I heard, things on follow through, on boundaries, and on counting. I think that Dr. Valdez's earlier remarks around the goals of AHRQ and the framework through which the investments are being made me think about the almost unique role that AHRQ plays in certainly the federal ecosystem of funding that I think just needs to be named is incredibly imbalanced toward trying to discover breakthrough innovations, all of the basic science that might predict the availability of new diagnostics, treatment modalities, ways of understanding disease and organ failure frameworks, atomized verticals of approaching the over 60,000 ways that humans get sick and our body fails. And I have no idea what the number is that other animals and worms and fruit flies and zebrafish and all those wonderful things that give us basic science insights. And they are wonderful. And it is very clear that for that $35 billion or more that's invested in those breakthrough innovation discovery type of research, only a small fraction, and most of it to AHRQ, not all, but most of it to AHRQ is really focused on what I'd call follow-through innovations. How do we actually deliver what the science tells us about understanding systems, and not just systems of organ failure, but systems of care, systems of health, or systems of inequitable health? How does that break down? For whom does it break down? Why does it break down? What are the reasons inside of healthcare and outside and peripheral to healthcare that health fails in clinical interactions, but also in community interactions or in systems of systemic racism or systems of broken financing mechanisms that do not actually pay for the type of care that we wish to see delivered equitably to our communities. So I hear very clearly a clarion call to focus on this translational research, using health services research as the basic science of follow-through innovation, but not being limited to the previous ways of knowing and ways of looking that probably aren't going to get us where we need to go, given the compounding myriad problems that we're facing and the more integrated view of things. And also makes me wonder how we expand and democratize the purview and the community of researchers, implementers, administrators, partners with AHRQ who are available and able to do the research. If we only ask the same people to do versions of the same research, we will get A versus A plus B versus A plus B plus C, but we might not get really new ways of looking at things, but also really new voices for looking at really compounded problems. I do think that in academia, and I'm speaking, full disclosure, as a member of an academic center that disproportionately takes research dollars, so I put that on the table. We need new voices. It can't be the same people, and it can't be the same institutions and the same schools, et cetera. But it does need this focus on follow through, because there's so little follow through focus versus breakthrough focus. The second area that I heard is about boundaries, and this one's a tough one. Boundaries, what I mean by that is we all know the very good science that is clear on what proportion of health is actually created by healthcare. Maybe 10% on a good day, maybe not. And yet AHRQ, as I believe Melinda Bunton said, is the agency for healthcare research and quality. It is a health services research agency focus. It is not my understanding, and certainly the money that flows into it is perhaps, we should open for discussion, not supposed to be completely, channeled on the widest conceptions of health and the causations for health that exist far outside of the healthcare system. So understanding where AHRQ's best boundaries lay, understanding that most of health is created outside of healthcare, and that so much is broken within healthcare, and so much is fixable if we name the gaps that exist between what we know should happen and what does happen, and focus the translational and implementation research on how to narrow those gaps, the narrowing of which will result demonstrably in reduced human suffering, reduced inequity, improved health of communities. And so I don't have an answer for that boundary question. Dr. Valdez, and you and your colleagues hopefully have an answer to it. The NAC members, I think we would do well to think about how we inclusively think about this community sociological financing health systems approach, but also, remember that there is so much that needs to be done within the healthcare systems and healthcare services. And finally, that gets me to the issue of counting. We've talked a lot about counting in many ways. We've talked about how we count and really clear pleas to make fewer, simpler, better measures that mean something to patients and professionals that actually have internal validity, internal face validity. The measure industrial complex has, I think we can all agree, gotten out of control. It's as much of an inhibitor of improvement as it is and actually, measure what matters, and you can't improve something that you don't measure kind of approach. We know it's critical. We have too much of it. And this is, again, new voices, parsimonious voices that really get us to 3 measures, not 30. I think AHRQ would do well and could do well to have a voice in that editing approach, in that not just adding new novel measures, but snipping away bad, silly, or even worse, measures that have unintended consequences that promote inequity. I think we talked a lot about counting in the sense of who counts and who is counted, and how AHRQ has a role to clearly be a clarion voice and agency for tackling inequity and naming ways, forms, and routes through which systemic racism translates itself, and through not just historical and sociological context, but onto people's lived experience and into their experience of poor health and the unfairness of that poor health and the consequences and remediation strategies that we then can use. And AHRQ has done some work in this area, and I think it's exciting to hear that it will do more. And I think that is clearly, making sure that everyone is counted and everyone counts equally is critical. And then figuring out how we count the dollars and where they flow, and how the dollar counting and the methods of payment, including new entrants into the market, really are clearly quite important to AHRQ's mandate. It's clear in the US, as in some other, but not all other countries, we have a delivery system that is organized on the basis of an idiosyncratic payment system that is most certainly broken and too expensive. And so AHRQ might, within its purview, be able to sponsor and promote research that not just counts the counting, but also counts how to count better and how to flow funds in an improved way to actually improve care. Because if you pay for visits and procedures and lasers and zapping and beautiful hospitals with glassy atria, then that's what you will get. And you won't get community-based primary care that's connected to public health that improves community outcomes. So just saying that that's an opportunity that I think you heard from the NAC members. And finally, to figure out the counting in terms of making sure that we have more people doing the work of all different disciplines. That was said by many, making sure that the work, even with this focus on patient-professional dyads, which is important, doesn't mean doctor-patient dyads, but it means all professionals that intersect and interact with patients and their families as they journey through the healthcare system. So those are my few comments, I welcome others.
Oh.
Joe Brown Spites.
Thank you. Very well summarized. I've given you major kudos, fist bump in the air, all those things. Excellent job. The only thing that I would add to your workforce comment at the end there is just the well-being of the physician workforce. I think that that's a really critical point that we might have some opportunity to really leverage how we do that well as far as taking care of them.
Thank you. Susan Edgman Levitan.
Thanks, Asaf. Just to build on what Dr. Brown Spites just mentioned, one of the comments I was thinking about making earlier, and it's actually related to something that Dr. Valdez said about the relationship between how we take care of our employees and how we take care of our patients and their families, and that intersection. And one of the areas that I think we could do more work in, and especially now, given the impact of COVID on the workforce, is we know from the CAPS research that organizations that are very high performers from the perspective of their patients, every single one we've ever studied is also the absolute best place to work. Because if you don't take care of your staff, you don't hire the right people, give them the right training, support them, and help get rid of the barriers to providing the care they came into healthcare to provide, you're never going to see positive patient experience. And with the, we also know that the survey of patient safety culture correlates with a unit or an organization or a practice's CAPS data, positively and negatively. So I think that the more that we can do to reinforce those kinds of analyses and that knowledge, and it's especially important, I think, for healthcare systems, because we don't have a universal mandate, that we look at how our staff, what our staffs think about the culture of their organizations and the kind of training and resources they get, which I think is really important, especially as we move forward with all the vacancy rates that we're all seeing and how that's impacting capacity and access. All of these things come together, I think, in very important ways that we need to understand better. Because the other thing that I think is really important with the culture of patient safety survey data is that we know that places that do really well have better outcomes, lower cost of care, et cetera, at least in the ambulatory setting. But we don't have as much information about what are the things that a practice or an organization can really do on the improvement side to improve the experiences that their staff have. So I think that there's a lot more that AHRQ can do in that arena. And I think it fits with the discussion we had earlier about building stronger relationships with healthcare systems and healthcare organizations.
Thanks so much.
Thanks.
Other reflections, comments? While others are thinking, I'll just ask Mamatha, any questions as the designated federal official for this meeting of the NAC?
No, not at this time. I just want to say thank you to everybody, and I will let maybe Dr. Valdez offer some final words if he would like, and then I think we will see you in July.
Great.
Thanks very much. And first of all, let me thank Dr. Beaton for chairing today's meeting, and done a marvelous job in keeping us on track. We even had a longer lunch hour than we expected, which I know my staff really appreciated. And I want to thank the staff because they have put in a great number of hours preparing and putting this meeting on. So I'm really grateful for their efforts and for their dedication to making your experience as NAC members both enjoyable but productive, because I know you take out time from a very busy schedule. So I want to be very thankful for the time that you've devoted to offering your advice, your observations, your suggestions, but to also invite you to not stop here. You don't have to wait till we have our next meeting in July. You can always find my Zoom door open, and please, by all means, send me a message or send me a note, send me a new idea, because if you're like me, I have to percolate ideas. I have to percolate conversations in my mind for a few days, a few hours, a few weeks, sometimes months before I actually, that's the question I need to ask, or, oh, here's the idea that will solve that problem or issue. And I invite you not to see our relationship as how we'll meet every kind of quarter or something. I really, some of us still actually do it the old-fashioned way. Some of you know I've given you telephone calls. I actually still know how to use the telephone. So, so if you feel free, you can give me a call, or you can send me an email, or we can do something even in between the WhatsApp and all those other kinds of technologies. I'm more than happy to interact with you on, and I invite you to not wait till July for our next interaction. And certainly, if you're like me, you need another couple hours to think about what your colleagues said, what we've presented to you, and also the issues that are pressing in your own professional lives, that quite honestly, we learn much of what we investigate as a result of the lived experiences that we have. So I want to thank you again for making the time to share your wisdom with us, and I really appreciate it.
Thank you so much, Dr. Valdez. A couple of final issues. So again, I think you heard loud and clear. If you have comments and thoughts that either percolate from this meeting, suggestions around topics for future meetings, suggestions about how today went, could have gone better, could be even more productive, please let Dr. Valdez know, Jamie Zimmerman, you can email me, all of the above, and we'll channel it to the right people. Again, this is a better set of meetings when we're all interacting and giving each other feedback on how to make it better and better. A big thank you to you, Dr. Valdez, as well as to Dr. Rhodes and Dr. Cohen for your presentations, for your words, for your comments on the entire sort of areas that we discussed. I want to thank the AHRQ staff and those who joined the meeting via Zoom for your participation. The next NAC meeting is July 21st, 2022. That's a Thursday, I believe. And a decision about whether it's going to be in-person or virtual will be made and communicated in the coming weeks. If you have thoughts on that, please reach out to AHRQ staff. And again, thank you for your time. In the last order of business, would someone like to offer a motion to adjourn?
Nobody wants to leave.
Any seconds?
Then I second.
Wonderful. The meeting is adjourned at 2:45 p.m. and thank you all so much. See you in July, if not sooner. Be well, be safe.
Thank you. Thank you for a wonderful cheer.